All right, so it is June the 15th. It is Tuesday. Yes, it is Tuesday because tomorrow's Wednesday. And we are going to talk about thorax of the ankle and foot, also talk about balance, which ties into the ankle and foot, which is, I kind of was glad these kind of merged together because they go hand in hand. And the balance lecture just got put up. I got to put that away. I'm going to sit playing with that controller all day. Give me something else. So we kind of already covered all the bones in kines, which is good because that way I don't have to recover them. One thing I did want to talk about that we didn't really cover yesterday, because I kind of glazed over it when we talked about measuring the ankle for girth. What was that technique you guys learned in PTA 110 for measuring the ankle called? The figure 8, good, right? And what were the bony landmarks for the figure 8? So what were the two superior landmarks? The figure 8 of the ankle, yeah. The malleoli were the two superior landmarks, good. Right, so, and when she taught it to you guys, did she teach you above the malleoli or at the malleoli?
At it.
Okay. So there are two different, so that's what Oscar brings up above, right? So there are two different techniques. There's the figure 8, and then there's the figure 8 plus 1. And I don't understand why it's called the plus 1. Please don't ask me why. That's what they call it, or the figure 8 1 is the other term for it. Most clinics do what's technically called the figure 8 1, even though they just call it the figure 8. And the figure 8 1 goes above the malleoli. So just understand that if you have to do a girth measurement at the ankle, you want to make sure that you ask your clinic, do they measure above the malleoli or at the malleoli? Because either of those is a valid measurement. It just depends upon the theory. And so here's the macro level kind of theory on this is, if you measure at the malleoli, you're measuring the swelling across the bones. Whereas if you measure above the malleoli, where there's more soft tissue, you're more likely to get an accurate swelling measurement, because oftentimes we don't swell right at the bone. We usually swell around the soft tissue, right? So it just depends upon what your clinic's doing. So just be aware of that if your clinic does at the malleoli or above the malleoli, either of those is valid. I haven't seen any that measure below the malleoli, but just as one of those things, just be aware of that your clinic may measure a little differently. And if it's the case, you just do what they do. Because again, if Oscar's out in his clinic and he measures at the malleoli and his PT measures above it, their measurements are going to be off. So you want to make sure you try to match everyone as close as possible to get that inter-tester reliability as close as possible. So then we take that kind of figure 8 around those, that top area, either at the malleoli or just above it. And then what are my two distal bony landmarks?
Navicular and
Got one? I got Truman's close with first metatarsal, but not
base of the fifth?
Base of the fifth. There we go. Good. Right? So so you're close. You're really close, Truman. You had the idea, right? But remember, navicular's on that first side. So that you're going to go at that kind of that navicular tuberosity, right? And then the base of the fifth. Exactly. Good. Those don't typically change. So those are pretty easy. And when we're measuring that, what we're really looking at is how swollen is the ankle, right? So if they've got a sprain, a strain of the muscles, if they've got anything else. And that actually brings me to a good point, because I had this question emailed to me last night. Well, Mr. McKeever, what is the difference between a sprain, because I kept using these terms interchangeably, and a strain? Well, here's the hint. They often get used interchangeably. But for your boards, good, Brooke brought it up, right? For your boards, this is the way I remember it. A strain has a T in it, which indicates tendon, which indicates muscle. Whereas a sprain is typically a ligament. And technically, you can even theoretically sprain your menisci. Right?
Fever, would you ever say that you strained your tendons? Is that possible, or is it just the muscle?
Nope, absolutely. You could, especially like, so remember we talked about Osgood-Schlatter's of the knee, right? Where that tibial tuberosity is really large. Technically, that is a strain of the tendon more than it is of the muscle itself. So yeah, you could absolutely strain a tendon. So that's why I kind of remember this as strain is tendon and muscle, whereas sprain is more ligament. So if you're in the clinic and Brooke calls and says, well, your patient has an ankle strain, is she going to be wrong? No, not really, because honestly, in the clinic, we kind of use them interchangeably. Sprain and strain. And if you ask 9 out of 10, probably PTs and PTAs, they probably don't remember what it was in school anyway. But by your boards, just remember that strain is tendon and muscle, sprain is ligament or whatever else, because you theoretically could sprain even your discs in your back, I guess, theoretically, I guess, right? So let's, I'm gonna kind of expound upon that. Let's take that up to the TMJ joint, the temporomandibular joint. Is that going to be a sprain or a strain when you have temporomandibular disorder?
Strain?
Yeah, it's a strain, right? It's the muscles, it's mainly the masseter, right? So good. I just want to use that as kind of an example because that's a really easy one to think about. You know, if you strain your quads, that's a strain, right? And strains then can lead to tears. But also, guess what? Sprains can lead to tears. That's why a lot of times, you know, they get used interchangeably. So for the person that asked me that yesterday, brilliant question. I should have explained that. But does that make sense, everyone? Everyone get that one? At least, okay, I got a nod or two. Yep, good. All right. So we talked about, you know, the whole forefoot, midfoot, all that fun stuff. One thing I wanted to touch upon that the Therex book hits that we didn't talk about in Kines is this term crural and sural, right? So crural means lower leg specifically. And technically, when we talk about the leg is technically the bottom part of our leg. It's not the whole leg. But typically when we say a crural injury, we're talking about tibia, fibula, and ankle, right? If we say sural is the back side of the lower leg, so that's calf, which is where you get that term triceps surae, right? Which we don't use as much anymore, but I guarantee if you run into PTs that have like an early master's degree or a bachelor's degree in PT, they still use this. I still use this term pretty heavily because it makes it easier than talking about plantar flexors, right? The triceps surae is your gastroc and your soleus, right? Gastroc has 2 heads. Soleus has 1 head. Soleus. So that means 3-headed lower leg back muscle. So we kind of got that idea at least. I just want to make sure that those terms, in case you get a question about that talks about the crural part or a crural injury, it's talking about the lower leg. Because the boards love to throw terms like that in and try to confuse you. Right?
Is crural just the front of the leg since we have sural, or is it the whole lower leg?
That's where it gets hinky. Technically, the crural is the whole lower leg. But in most points, when they talk about a crural injury, they talk about the anterior surface and the sural being a posterior surface. So that's one of those that it gets weird. Technically, the crural is just the whole lower leg, right? It's the crural region, just like the forearm is the whole lower arm, right? But in most divisions, they'll talk about crural being anterior surface and sural being posterior surface. This is a thing that actually, because I didn't talk about this yesterday, why do we not have 15 phalanges? What's missing an extra phalange? Big toe, yeah, right? And you got to think about this, because I was actually like thinking about this a few years ago, and this is how my brain works. how much more fine movement might we have if we had that extra phalange on our thumb? Would we, I mean, it'd look weird, right? But could we do, yeah, more curling, stuff like that? I don't know. It's just weird. I thought about, these are the weird things I think about when I'm studying for anatomy for Dr. Johnson's class. Like, why don't we have that? What really caused, where in, evolution did we decide we're only going to have two there? So when we talk about the joints, we talked briefly about this. We have the superior, better thumbs up, exactly. Bing, bang, bing, right? Superior talofibular joint, it's a synovial joint. Inferior talofibular joint was the synostosis. And both of those kind of help with dorsiflexion and plantar flexion for fibular head movement. I like this chart out of your book, so I put this in here that talks about the roll and slide when we talk about the joints. This is not something you're going to have to memorize, so you do not have to memorize that for a test, okay? And your boards are probably not likely to ask about this. The boards typically don't ask. I mean, they may, if they ask you about spin and glide or roll and glide of a joint, they're probably going to ask you plantar flexion, dorsiflexion, and either closed or open chain, right? But for the most part, I put this on here again in case you're in a clinic that deals a lot with the feet. This is a really good chart for it. That's what I was going to say. That's what I was getting at, Stephanie, is if you're in a clinic that deals with a lot of feet, this chart's really useful for kind of going back to and referencing. I wish I had this chart when I was doing it. My chart that I had for the foot was ridiculous. So one of my kinesiology instructor was a certified hand and foot therapist. And oh my God, like literally we had to memorize every single pulley system of the foot and the hand, and my head exploded. I'm not going to be that mean to you. I'm not certified in either of those, and I wouldn't be. It's just too much. But let's think about this just real quick. So here's my fine fibula. Really poorly drawn. Here's my tubby tibia. Should have added the malleoli. There's malleoli. Here's my talus, right? So the talus is what's really primarily acting in that dorsiflexion plantar flexion roll, right? So rolling that way or that way. So remember that in an open chained activity, so if my foot is off the ground and I'm doing dorsiflexion plantar flexion in the air, right? That means it is a convex surface moving on concave, right? If I'm doing something like standing up, at that point, it's the tibia and fibula forming that cave surface moving on the vex. That gives you a really good kind of thought process on that, that if the only two ways they can really ask you questions about this is floating in the air, right? Or in gait or standing up. So if it's in the air, it's a vex on a cave movement. If it's anything else pretty much that you can think about, it's going to be the cave on the vex. Because even when we're walking, it's the tibia that's moving. It's not necessarily the the talus and the calcaneus moving. So I just kind of wanted to make sure you kind of understand that. In supination pronation, I'm going to say 99.9% certainty they're not going to ask you a roll, spin, glide on that, because here's a hint. Even most therapists don't understand it. Same thing with inversion, eversion. So if they're going to ask you a question on the boards, they're going to ask you plantar flexion, dorsiflexion. And you just have to be able to figure out, again, the first thing you get, if it's like ruling with the convex concave rule, right? You see that convex concave rule, the first thing you do is go, okay, what bone is moving?
So they'll probably tell us like it's gait or it's open
Right.
chain.
So they would say, for example, they would say something like, during going up and down stairs, according to the convex concave rule, the tibia is moving in what relation to the talus, right? Or they'll say, while doing ankle pumps, which would be open kinetic chain, right? The tibia is moving, yeah, that type of a thing. Actually, at that point, the talus is moving in relation to the tibia. Does that help clear that up just a little bit?
Yeah.
Okay, cool. The ankle ones are kind of the most simple just because it's kind of really easy to visualize it. Hold on here a second. Yep, I'm listening.
So if you're doing the ankle pumps, it's the talus moving against the tibia, right?
Yep. So like here, let me switch again. I have switched to just wearing shorts from now on so that we can demonstrate lower extremity. I don't really like shorts, but right. So if I'm out here in the air and I'm doing ankle pumps, the tibia itself is fixed, right? Because it's not going anywhere. But my talus is the one moving out there.
And is that okay? And is that the same for against gravity when your foot's on the floor?
Yeah, even if I'm on the floor, sideline, whatever it is.
It's always okay.
Yeah, as long as it's open kinetic chain, the talus is the part moving.
Okay.
Right? Now, again, if I'm standing up, so if I'm here and I go to stand up, now my talus is fixed and it's my tibia that's doing the movement. Does that make sense?
Yes. So another thing we have to look out for is the closed versus open packed.
Well, not for terminating roll, spin, and glide. That doesn't really matter.
Okay.
Right? Again, closed versus open pack really only matters in mobilization or stabilization.
Okay.
So if I was to ask you, Brooke, if I said your patient suffered an ankle fracture, what position is the doctor likely to cast them in? I'll answer that question in a second, John. What position is the doctor likely to cast them in? That would be a closed pack position, right? Because they're going to cast them in the most stable position they can cast them in.
Yes.
That would be a closed pack versus open pack. Or if I asked you what position would you mobilize the patient in, that would be open packed.
Okay.
Right? But for closed kinetic chain versus open kinetic chain, it's just which part's moving.
Okay.
Right? And so John just asked, calf raises would be closed. You got to think about that one for a second. Yeah, actually, you're right, John. You're 100% right. It would be closed connection. I had to think about that for a second because I guess in a way, I could argue there's simultaneous movement a little bit, but I would say that by rule of the law, it's closed kinetic chain. Yeah, because the distal end would be fixed at that point. That's a really good one, though, John. Yeah, the tibia is the part moving. Yep. Tricksy Hobbit, John. Tricksy Hobbit. So John asked about calf raises. Calf raises would definitely be a closed kinetic. Dr. A is going to pop in at some point here to give us an update on clinic. So whenever she pops in, I'll give her the floor here, but we'll keep going for right now. So when we have a structural relationship, what that means is that everything is tied together, right? The lower leg motions are tied together with the foot motions are tied together with the toe motions. So when we talk about the full kind of lower leg, the crural region, including the foot, all of those motions work together simultaneous to allow movement, right? When we have supination or pronation of the foot, there's going to be a little bit of rotation going on at the tibia. I think that probably is Dr. A popping it is. So again, remember I said this, you don't have to memorize the motions of supination and pronation for the boards themselves. You have to understand they exist in the foot. And just like that, here, when there's supination, pronation of the foot, there's going to be slight rotation occurring at the ankle or at the tibia, but not much. Again, the tibia is a pretty fixed bone. It's not like our radius and ulna where they do that twisting motion over each other. That would be kind of weird if we had that at the foot. Hey, Dr. A, how are you doing?
I'm good.
Do you need to give them an update? Is that what you said?
Oh, whenever you're at a good
This is a perfect point. We can pause the sharing here and I will give you the floor for a few minutes. You are not interrupting anything. Let's replace spotlight. There's Dr. A.
Take the paper off my camera. Hi, everyone. So I wanted to give you an update on clinicals. I have emailed everyone. Hi, John. I have emailed everyone your contact information for your site, and you're going to use that to write your introductory letter on Blackboard. submit your first draft to Blackboard, and then I will make corrections on it. So even if you get a perfect 5 score on your letter, please look at the comments because there could be corrections that you need to make on your letter before you send it out. You don't have to resubmit it, just make the corrections before you then email it to your site coordinator of clinical education, the SCCE, okay? Please have those letters submitted to Blackboard by Friday. Again, they're literally going to take you a minute and a half to do. So try to do it as soon as possible so you can reach out to your new site by this Friday. And what else did I want to tell you? The clinical site information that I emailed to you, if you scroll all the way to the bottom, you'll see any special considerations or materials that you should be reviewing before you start the clinical rotation. Now is a good time to start reviewing because you don't want to get to like the day before or the week before and look at your list and be like, oh, wow, this is going to take me, 8 to 12 hours to review all this stuff that I'm going to need to know on my first day. So please take a look at that list at the bottom. Some of you have extra things to do that not all sites need, like you'll need it like some kind of immunization that's unusual, so the school doesn't require it, but you do have to have it to go to your site, or you have to send your resume to the clinical site. Some of them require that. So make sure that you get all that done and sent to the site by this week. For some of you, there's extra information handouts that previous students have recommended that future students take a look at before they go to the site, like for specialty sites, and I've sent that material to those people. And then, so now what I'm working on while you guys start getting in touch with your clinical sites, I have to wait until I get your CI information before I can do that. And that is setting up your electronic timesheets. But that's next on my list, but I have to wait for you to submit your CI information. If we have tattoos, would there be a way to incorporate into our letter if they'd like us to cover? Go ahead and cover on the first day. And then if they say, do you have any questions for me? Then you can say, hey, I have these sleeves on today, but I have tattoos. Do you want me to keep them covered? So I would walk in showing that top level of, professionalism.
Yeah, same thing for any piercings, just to add to that. If there's anything that's abnormal, don't put any new piercings in that you wouldn't put in here at PIMA.
Right, and the PIMA dress code is 1 ear piercing per ear. And it can only be a stud. It cannot be something hanging. So if you can see what I'm wearing, even that would not be allowed because it's hanging. You can only have a stud in, like, I don't know, diamond or pearl or whatever kind of stud is professional looking. So you don't want to put like a big spike stud or anything like that. Remember, the first minute that you walk in, you're going to be establishing your reputation with the clinic. And that reputation will be spread around the community as you do more practicums in different places. And I prefer granite studs because they rock. Good Lord. It's too bad Mr. McKeever isn't funny. So remember that, the first minute you present yourself, you are setting a reputation. And if you go in looking like, not a professional PTA student, then they're not going to think you are. So if you want to be thought of as a professional, mature, intelligent PTA student, then present yourself like that. I'm assuming we should go in wearing masks. Yeah, absolutely. Unless when they respond to you in their email, they say, oh, masks are, if you're vaccinated, you don't have to wear a mask, but you'll have to bring your card to show us. If they give you a scenario, then you just follow that. Oops, I missed that. Let me read that chat. Pretty much do anything the opposite of what I do. And Again, showing up with a mask shows the optimal level of professionalism, that you are ready to protect everyone there from anything you are carrying. And if they say you have the option to take your mask off, then you have the option to, okay? Keep in mind that you're not 100% protected by vaccinations. You're only 95% protected. And if you get sick, you could possibly not be able to finish your practicum, and then you would be out of the program. And so if you're given the option to wear a mask, that might top off your vaccination and make you 100% protected against the virus. And then you get all the way through your practicum without being sick. I think that's a huge advantage.
And one other thing is, don't forget that even with the fact that you may be vaccinated against COVID, you may not be vaccinated against like pertussis or something else that might be in the clinic. So the mask could protect you. They had a question about materials they're allowed to bring, Dr. A. I don't know if you saw that.
I didn't, but now I see it, but I'll get to that in just a minute. I do want to say, you know, I try to keep up with the latest statistics and research and stuff. And today I heard that science is telling us that with the new mutant variants, especially the Delta variant, we are still protected by, the research was for Pfizer and AstraZeneca. For Pfizer, you are protected 75% against the mutant variant. And AstraZeneca, it's 60 something. I can't remember the exact, it's in the 60s. 63? Yeah, 63%. So you know that we didn't have AstraZeneca here in the US. We had that's a one shot that they have in Europe. We had J&J, which is a one shot, but I didn't hear any research on that yet, and no research on Moderna, unless Mr. McKeever has heard about Moderna's level, nothing yet. Okay, so realize this is 20% less effective against the mutant variants they are in Las Vegas, the mutant variants already. Well, they're in Nevada. So we did have 95% protection against the original virus, but the mutant variants are a little different. And so we have 20% less or 30% less protection against those. That's where masks come in. That's how you can give yourself, masks apparently give about 45% protection. And so before we had vaccines, if two people were both wearing masks, then you would have 90% protection, right? But if only one person was wearing a mask and the other person wasn't, both people only had 45% protection. So if we do the math, it makes sense to wear a mask. You will have the option to wear a mask, and I highly recommend it, so that you don't get left behind in the program. That would be tragic after all your work. Okay, are we supposed to get boosters for the vaccine? As soon as I know anything, I'll tell you guys. They don't have a month yet, like a month when you need to go get a booster. I heard 12 months bandied about this morning on the news, but there's nothing specific, but we'll let you know as soon as we find anything out.
Yeah, so they said that I was watching one of the CDC things on that, and they said that they really won't know until we hit flu season what type of boosters we might need, until we kind of get the 6th season going to see if we need it.
Oh, so they have to do kind of a stress test on it.
Exactly, yeah.
To find out. So we literally don't have the real life statistics to know about that. But that could be a really useful tool for us, is the booster shot. Does everybody need TB annually? Yes. And that's why I sent out reminders, even though, don't count on my reminders, you were supposed to put it in your phone calendar, right? To remind yourself every year to get the TB test and to get a physician release. And I tried to send as many reminders as I could to people who theirs would expire before the end of the first rotation. So you'll definitely want to get those in. Let's see. Yeah, and the TB is for the rest of your career. You won't be required to get a physician clearance the rest of your career. That's for practicums, but plan as a healthcare practitioner, you will have to get a TB test every year. Okay, let me scroll back here. Can we bring references? Let me go see Amanda's question. Are we welcome to bring references into the clinic like books? Yes, you'll get extra credit for that. You walk into a clinic on the first day carrying reference books like your books from school, you will already be rated at 5 out of or 11 out of 10. Because CIs love to see that students bring reference material with them. Yeah, because they know we can't rely on Googling stuff on our phones because that looks unprofessional to patients. So if we have books that we can use as reference, you'll establish a good reputation like that. Did I miss any others?
They asked briefly about laptops, and I would say that is a site-by-site basis. I didn't mind it when I was a CI, but some clinics don't want you having any electronic devices on the floor or anything like that. So that would be something to talk to your CI about. At least I'm not stepping over my bounds here, but that was one of the ones they had.
That's true. Bringing in your own laptop, that's like bringing in a big phone. And if you want to have the best reputation in the clinic, you'll have a backpack. You're going to put your phone in the backpack in the staff room, and you're not going to look at it until lunchtime. And then you put it back, and again, you don't look at it again until your shift is done, because clinical instructors and staff, when they see students on their phone, they think they are not paying attention to their patient and they're not taking their time there seriously. And why should they offer that spot to a student if they're not going to take it seriously? And if you do it once, that's it. That's your reputation, is that you are not attentive to your patients. Okay, so you have to tell your family and your job and stuff that you can't answer texts, phone messages, or emails except at your lunchtime break and then after your shift. So everyone has to know to expect they cannot communicate with you while you're doing patient care. Thanks for answering that question, Mr. McKeever, on J&J. I heard somewhere that Moderna is giving even better protection than Pfizer for the mutant variants, but I haven't found the research on that yet. So, but I heard on BBC or something that Moderna is like top of the line. It's giving people the most protection against me, but I don't have the numbers for that.
Yeah, the only thing we don't know yet about is that the Indian variant, which we don't know much about right now. So that's the only concern that's out there.
What do we know about Moderna and the UK variant and Brazilian? Anything?
It's resilient against those, so.
Okay, but probably at a lower level, just like Pfizer.
Yep.
So is the quantiferin TB test? Quantiferin is usually used after someone's had a positive time test, the injection test. There are some sites that will not accept a quantiferin test unless you have proof of a positive time test or the injection test. So if in your history, anytime in your life you've had a positive injection, the TB test with the injection under the skin, and then your doctor switched you over to a quantiferin test, that's fine, but you have to show proof of that positive finding first. It's a little bit complex. I'm sorry about that, but that's what sites are looking at. If they have a specific requirement, if you have a TB test and they're like, oh, well, we require this other test, then you'll just have to go get that other test.
Yeah, I'm going to piggyback on that because I have a positive TB test every time I take it, and they require me to show the positive TB test plus my quantiferin plus a chest x-ray at some sites too, depending upon what they require.
Yes, some will also require, or your doctor will require you to go and get a chest x-ray as well to make sure you don't have any of the disease. Because it's a lung disease that people get. The other, and I don't usually like to pass on horror stories, but I communicate with all the other PTA programs in PIMA, the campuses in other states, like we have 2 campuses in Colorado, we have Texas, we have Washington, and we just had a chain email today that 2 campuses have had students dismissed or terminated from their final rotation for professionalism issues. And that's all happened within this week and a couple of weeks ago. So the clinical sites are coming down hard on professionalism. And so you might be thinking, well, what is it? Like, what do I have to do to not get dismissed? Because if you get dismissed, that means you're terminated from the program as well. No matter what time, even if it's like 2 weeks before the end of your final rotation, if you get dismissed from your site, there's no, that means you're terminated from the PTA program. So how can you avoid that? And that is by always acting and speaking respectfully, wearing what you're supposed to wear, whatever their dress code is, abiding by that. And that's going to include keeping anyone with hair that's longer than your ears, keeping it tied back so that it doesn't fall into your workspace or onto a patient or anything like that. Some students are just like, I don't want to put my hair up, it ruins my hairstyle. It doesn't make me look pretty. Well, this is not the profession for looking pretty or making you feel glamorous. This is a healthcare. You're there to be not a danger to someone else or yourself. And if you're not willing to do simple things like have your hair back, then the clinics are simply going, they don't want to deal with anyone who's argumentative or will not act professionally in a healthcare setting. And so they are just letting students go. They used to call the school and try to have tutoring sessions and meetings and stuff like that. And they're not even doing that anymore. They're not giving students any second chances. You're going to get a chance to practice these behaviors when you go into lab with Mr. McKeever. And so that's why you need to practice abiding by the PIMA dress code. If you haven't read through that recently, please do. It's very easy to have your hair down and these hanging earrings and whatever else, artificial nails when you're on Zoom, but all of those are against the PIMA dress code. And that is because the facility, the clinics do not allow that. No artificial nails, no color nail polish, no hanging earrings, no hair down in the face. These are all infection control measures that were in place far before COVID, and they especially apply during COVID. So I don't know where to direct you to see the student manual. I'm not sure where Dr. O'Neill put it, but the dress code is in there.
I can repost it in this class, actually. I'll just download it and repost it.
Oh, cool. That would be great. Mr. McKeever is tying his hair back now. You can have clear polish, but if you look at my fingernails, they're even too long. Like you shouldn't really have any white. You should cut your nails down so there's almost no white on your nails. So you need to do this for lab too. This is PIMA dress code. What is the difference between natural polish and clear? I thought clear polish was natural.
Some people wear like skin toned polish.
Yeah, so there should be no opaque polish. You can just, it's clear and that's about it. Because when you have polish on your nails, it apparently around the edges and stuff, and especially if you have artificial nails too, bacteria can stay in there and you can carry it from patient to patient. Natural French tip. No. That French tip has white.
Here's my other thing on it. In case you ever do wound care, that stuff can get in the wound. Usually the clear polish doesn't chafe and chip, right? It's just a lacquer type stuff, and that stuff, is based on acetone and stuff like that. If that were to get in a wound, it's not going to be a major deal. When you have a dyed nail polish, it has specific chemicals in it that can infect the wound. That's one of the reasons why for this.
Yeah. And then again, a French tip has the white at the tip. And that's exactly what I just said. You need to pretty much cut off the white in your own nails. And so you wouldn't be able to have a French tip on there because they should be too short for that. Okay, so I'm sorry if you didn't know that physical therapy is not a glamour setting to be in. You also cannot wear any kind of perfume or anything with, that has an odor to it. Aftershave, body spray, can't have any of that on the clinic. Now, what you do outside the clinic is great. I mean, if you want to go out, if you're going out for a night or whatever, put nail polish on, put green spray in your hair. It doesn't matter what you do outside. It's just when you're doing patient care, and that's all for infection control. Do you wear gloves? That's going to be up to the clinic. If you have any cuts or anything on your hand, you definitely want to wear gloves because you don't want to get any infectious material into your hand, because you could certainly catch anything that way. COVID, flu, whatever, bacteria. But if you are, whether or not you wear gloves, you will have to foam in, foam out, use hand sanitizer and wash your hands. And so if your skin is intact, you don't have any cuts or punctures on your hand, no irritation from manicures or anything like that, you may, in outpatient, you might be able to not wear gloves. Inpatient, I'm assuming you're going to be wearing gloves all the time. Yeah, no X. Let's see. Right, so Mr. McKeever is going to post the dress code part of the student manual for you guys to review and really try. I mean, before the pandemic, students were practicing this every single day when they were in school. You're going to have the last, I don't know, 4 or 5 weeks to practice it when you're there for lab. So take everything seriously, help your classmates, remind them. Don't like call them out or anything, but say, hey, you're supposed to cut your nails, for tomorrow. And just help each other learn all the parts about the dress code. Just to be clear, the 2 things we have to renew before our second rotation is TB shot and some people have to renew because everyone got them on different dates. Some people have already renewed, so they don't have to renew again. It depends on, you have the TB and the physician exam lasts for 1 year. And so if that expires before August 31st, then you definitely need to renew it before you even go. Because if it expires like August 20th, then we're going to pull you out of your practicum just because you didn't renew it. Like that would be bad. Don't make me do that. What else? Right. So just in your head, get prepared to practice this professionalism. It also means you're not going to use street language. You're not going to use any kind of sarcasm when you're talking to other clinicians or to patients. You may as well practice that in the lab. Speak positively to everyone. And it doesn't mean to be formal. It just means like, don't use the language that you hear in, movies and stuff like that. Healthcare practitioners rise above that and we speak maturely and intelligently with each other and we stay positive. And so, if a student goes into a hospital and is like, yo, what's up? And
we've had that.
We've had that. Or they say like, that's so stupid. We never did that in school. And that's very negative and that's very closed-minded. You're obviously going to have to learn new things in the clinic, and I'll be talking more about that before you go out. But if you think about doctors and nurses that you have been around when you went to the doctor's office or to the hospital and how they seem so grown up and so mature, well, you need to start practicing that too. Whether or not you feel like that inside, however you feel inside is how you feel inside. I mean, don't deny that. It's what you say and what you do and your body language that you have to learn how to act the part of a healthcare professional. And from the emails that I got today, it seems like it's more and more and more important because you could be the smartest student ever and know all the information. But if you speak disrespectfully to a patient or you make an off-color joke or you refuse to learn something that you think you're not interested in, the clinic is not going to waste time trying to re-educate you. They don't have the time. They are very stressed about COVID. They don't have enough patients coming in to pay the bills. And here they are taking a student. So, you have to present as someone that they want to keep there. And you can practice that in lab. Okay. Even though you're going to be allowed to be in shorts and things like that, you'll be in casual clothing, but you still need to act like a professional.
I think I'm going to have a day where they come in full dress just as a kind of dress rehearsal. Actually, now that you mentioned that, I put that down as a note.
That's great.
I think that would be a good thing.
Yeah. Yeah, that's a great idea. Yeah, because otherwise they won't have a chance to do that. Yeah.
Doctor, you want to mention about scrubs as well? That way they know how the process. That way if they need to order them, because I just thought of that. So that,
Yeah, thank you. So not everyone gets scrubs. It's not automatically handed out to people. But if you're in your letter, you'll see when you write your letter that it asks what's the dress code there. And if the facility says we require scrubs, if they will accept dark blue scrubs, you can get one pair of scrubs from PIMA. And I have to verify that they have requested that from you as well. So you'll be double checked on that. So and then let me know, and then I will give you the email of the person to contact on main campus, the big building next door to our suite, who will arrange for you to pick up one pair of dark blue scrubs. If they need any other color scrubs, or you want more than one set, then you can go and purchase that. And there are places to purchase that for pretty inexpensively, such as Talus. What's the other one? Walmart. Those are the two big places. You can get any color, sometimes fun patterns. So it depends on what they require. Like some places are like, you need a dark maroon. So you just go and buy a dark maroon set.
yeah, Freedom's another one. Yep.
Freedom. Never
Yeah.
heard of that. Cool.
They're a little more expensive than Walmart, but they exist.
I also bought scrubs from Amazon. So since we have plenty of time before your first day, you can do that too. And I thought the price was pretty good, but I think Talus was the cheapest as far as price, but they don't always have every single color and every single size in stock. So you can also order online. So basically, if your place says you need to have scrubs, then and if they say dark blue, then get in touch with me and I'll get the process going for you to get your dark blue scrubs from PIMA. If your facility does not require scrubs, then you don't get a free pair from PIMA. Oh, any questions?
I was going to ask for future practicums, if I wanted to try and reach out to a clinic and see if I can work there, what's the process and what information do you need?
Is this a place in Las Vegas?
Yeah.
Okay, so as an enrolled student in a PT or PTA program, you cannot reach out to any clinics in Southern Nevada. And this is because if any were allowed to do that, then all would have to be allowed to do that. And the clinics would be inundated by phone calls from students. And they don't want that. They're too busy. That's why people like me are hired. As a clinical director, I'm supposed to be the one who reaches out to clinics. So, and the site selection process is as you just went through, where I post a list of what's available, and then a student can pick from that. So a student can't request a specific placement in town, because for every rotation, I contact every clinic in town that is willing to have a contract with us. And I say, do you have a spot for a student for December? And they say yes or no. And then I put it on the list. So that's how it works.
How did some of the students, because wasn't it only 20 of us out of 25 selecting, how did some of them get selected to other sites without doing that process?
A bunch of people requested to be out of state. So we have students going to Hawaii, New York State, California, and some other states. So they contacted me, and I did find they're not allowed to call those clinics either. So I was the one who reached out to clinics in other states. That's why there were less than 25.
Okay, thank you.
On that list. Yeah, good questions.
Dr. Breskin, I have a
Yep.
question in regards to the quantiferon TB test. Now, I did mine like before the program started, so I'm going to have to redo it. But you said that we have to provide a previous positive one, but I thought, I could be wrong, but I thought in the details, it was the quantiferon was accepted for the like negative TB result. And that's what I did end up turning in initially. I've never been tested positive for TB before. But again, I could be wrong. I thought that the quantiferon TB blood test was accepted though.
While she answers that, Amanda, I'm just going to chime in quick while she goes and looks for that.
Sure.
That one's one of those that's oh, did she just drop? I think Dr. Reskin got kicked. Uh-oh. She'll rejoin. One
She
of
said she doesn't want to answer my question. No, just kidding.
no, I think she stepped over. I think she tripped over her cable.
Oh.
Because I saw her kind of stumble and think she probably tripped over her network cable. So the only reason I say that the way I answered it was that, it depends upon the clinic, because I have been at clinics where if you do have the quantiferon, they require it. I'm pretty sure that's probably going to be the response. Most clinics will just take the quantiferon. Like I've at one hospital down in Tucson, no problem. I gave them the quantiferon, not an issue. They were fine. One of the outpatient clinics I went to said, well, if you have quantiferon, why do you have quantiferon? Do you have a positive TB test? And I'm like, yes, I have a positive TB test. And they're like, okay, can you demonstrate that to us? So that's one of those, yeah, her battery ran out. That's what she just said. So it just depends. And I'm sure that's what she's going to, I think she's looking in the book. She's getting back on now. So it's funny that you kicked her out of the room. That's hilarious. But yeah, so it really does vary a little bit on that. When I was a DOR, I didn't care. As long as I had a quantiferon, or whether I had a chest x-ray, or whether I had the negative TB test, I didn't really care, because to me, they're all kind of efficacy the same, if that makes sense.
Yeah, because I believe that like in the packet of like that we all had to turn in prior to the program.
And that's what that's probably what she's checking. Because again,
Yeah.
some of this stuff has changed recently, so I don't blame her for being, I got to check really quick.
No, got it.
Yeah, because we've had some major changes in the way some of the clinic, like this timesheet thing she has to do now, is a nightmare. I looked at that. It's not the for her end. You guys, your side of it's beautiful. Like the timesheet you guys have to fill out is fantastic, but man, on the back end for us, it's not pretty. So yeah, I don't have the clinical binder handy, so I wouldn't. She'll be on and can answer that in a second. But like I said, sometimes even with that, clinics will be a little bit testy, and most of the time they'll just be like whatever and just take it. And the only reason I could see that is specifically like if you're working something like an LTAC would be an example, where long-term acute care. Whereas if you had quantiferon, their concern is, oh my God, you've had a positive TB test. And if you have a positive TB test, doesn't necessarily mean you have TB, right? What it means is you have antibodies for TB, which means you may have had it, you may not have had it, you may have a latent infection, meaning it's just sitting somewhere in your body. And so that's sometimes the concern for the LTACs is they're like, okay, well, you're coming into somebody that's in a coma or something like that, and you have a latent TB infection. We don't necessarily want you coming in unless we can prove that it's not circulating in the blood, which is what the quantiferon test tests for. So it can be a little hinky, but most of the time you'll be okay. Like I said, she's checking right now. She can't find her power plug. There she is. Oh, you scared her away, I'm telling you. Let's see, she's coming back. There they are. Spotlight for everyone. Yeah, she scared you away, Dr. Freskin. I'm staying.
That's what happens when you don't plug in your computer. I didn't think I'd be on that long, so I just didn't plug it in.
Likely excuse.
I have to. So okay. Oh, I lost all the chats.
Well, so I basically, I was talking while I was waiting for you to come back. I just said that, even in some clinics, even if it was acceptable, I don't remember what the clinical binder I said, but even if that's acceptable, the clinic could still request a positive TB test. And that's was kind of what I was saying. So, and I kind of basically explained kind of the way those tests work is what I was just going on while I was delaying is what I was really doing.
No, that's actually true. Some, there are some clinics who will be like, oh, anything is fine. And then there are others that are like, no, you have to have the positive test and I have to see that result on a document. And then you have to show that you were referred for the quantiferon because they're really strict. And so, we don't want, there were enough of those that we had to put down that, you know, that strict requirement for quantiferin. It's a good question. I mean, I know it's weird that different clinics have different standards, but there are different standards out there. There are some, like for instance, there's the varicella vaccine is now a 2-step, but none of our clinics have informed me that they require the 2-step. Supposedly they're all okay with 1-step. So until I get the majority that say, yes, the students need a 2-step varicella, then we're keeping it at 1-step. So it's you know, the list of immunizations that I sent you is constantly, you know, adapting and changing. But that's where we're at right now for varicella and for quantiferin. Any other great questions like those? And like I said, I'm gonna be doing a very thorough orientation for you before you go out as well. So don't
Yeah,
worry.
sorry. I just want to make sure I renew the right TB test. Because I have the email that you sent out last year open right now, and it says the two-step TB required within the last year, or proof that you started the 2 TB test, and then it says or proof of the 2 test or 2-step at any point in your past with proof of yearly TB tests every year since the 2-step.
Does that make sense to you?
No, not the second bullet. So if I've already taken a 2-step TB test, I just have to take an annual TB test.
And you have to submit proof that you've renewed it every year
Since the 2-step.
since the 2-step.
Got it.
Otherwise, the facilities will say, well, you know, she had the 2-step 5 years ago, but she's only had two renewals, 2 single-shot renewals since then. That means that you let it lapse.
Got it.
They're going to say, oh, well, she needs to do a 2-step right now.
Yeah, for example, I missed my single step last year, so now I have to go back and do another 2-step, and then also do all the fun stuff. So yes.
Luckily, TB is the only TB. Well, COVID might join TB for a yearly booster, but for right now, TB is the only thing that you'll have to do every year as an employed PTA. So there's that. At least you don't have to repeat, like, you know, varicella and polio and all that stuff. You're done with all that for the rest of your life, from what I know. What is the blood test for? Which blood test?
I think she's talking to quantiferon, maybe.
Yeah, that one.
Yeah, it's an alternative TB test.
So yeah, so the blood test basically, again, it's if you've tested, because I've had this, it's the only reason I can speak from kind of experience on this, is if you test positive, typically the facilities are going to request one of 2 things or both. And again, that's a chest x-ray to make sure you don't have active TB in your lungs anywhere, because that's where it exists. Or the quantiferon test will test to see if you have antibodies or active TB in your blood. So that would be one of the reasons, like when I get my quantiferon or my 2-step test, I pop positive because I have the active antibodies in my blood. So the test is kind of really specific for that, because it tests for antibodies or antigens. And so then the quantiferon says, okay, he has the antibodies, not the antigens active in his blood.
And if you think about it, why do we have to do a TB test every year? Why don't we just get the vaccine? Because there has never been a vaccine developed for TB. And this is why you won't have to ever take a COVID test every year, because you're just going to get the vaccine. We're just going to prevent the disease altogether. But we've never been able to make a TB vaccine. There is nothing like that available. And so we have to test. And if someone is positive and then they do a chest x-ray and they find that the person actually has the TB infection in the lungs, then you take massive amounts of antibiotics because it's a bacteria, right? Correct? So there's a treatment as long as the antibiotics are effective, but there is no vaccine, unfortunately. Now that's not the case with the polio, the hepatitis B, the MMR, and all those other vaccines that you got. You know, you only had to do 2 or 3 of those, and then you're done for your whole lifetime. You're immune for your whole lifetime, and that's the case with COVID. So we got lucky again with COVID. TB is one of the, TB and measles are the other 2 airborne diseases, which is what COVID is. So thank goodness we have vaccines and or treatment for each one. So TB is airborne, and so it's very easily infectious and contagious. Oh, Legionnaire's disease. So I mentioned before, after first, the second one starts November 3rd. So you have after your first practicum, you have a week off unless you have to do makeup hours to finish practicum 1. And then you have 8 weeks of classes, and then practicum 2 is 7 weeks long, and it starts November 3rd and goes until December 21st. It goes right up until Christmas vacation starts. The holidays vacation starts. There was another question I didn't answer here. Let me scroll back here. Bianca, yes. So like I've been saying, most of the vaccines that you got are good for a lifetime, but TB, you have to test for that every year, and the physical exam has to be renewed once a year. And so if your TB test and your physical exam expire before the August 31st, then you need to renew it before you start on August 18th. Let's see. Okay, any more questions before I stop interrupting Mr. McKeever's class? Okay, you can always email me with questions too. Copy that. All right, bye you guys. Okay, so wait, sorry, I said a lot. So your next step, read the email that I gave you and the attachment with all the information, write your introductory letter, submit that to Blackboard. When I grade that, read the comments, make any corrections that I say you have to make, and then you can send that email. Please get that done by Friday so that your clinics hear from you by Friday. The step after that, when they send you the information for your CI, for your clinical instructor, their name, their email, and the years of experience they have, then you're going to enter that into Blackboard too. There's a survey on Blackboard for that information. And at that point, I can start creating your timesheets. Okay, but so just focus on writing the letter this week. Bye.
All right. Do we need a bathroom and snack break? How's everyone feeling? Anyone say yes, no? Brooke says yes. All right. Stress. Now, I can't help you take a stress nap, but how about we take a 10-minute break? We'll come back at 25 after, and we'll resume and get back to class. And then if you think of anything on that break, come back and ask. So let's just take a quick 10-minute break and go to the restroom, get a drink, and be back here about 25 after. So we're back from break. Copy that. So we talked yesterday briefly about the arches, right? We have our longitudinal arch, and then we have our kind of our medial or our lateral arch as well. Those technically by the book are called twisted osteoplate arches. Again, not that you really have to know that, but that in the anatomical term, it literally means that they're that way because there's a bunch of twisted cables that kind of run bone to bone. Primary support we talked about is that spring ligament that helps us kind of bounce, right? It's what helps tiggers bounce. We have our long plantar ligament, plantar epidurosis, all that fun stuff. There's very little muscular support in the arch, like I said, but we can help our arches by strengthening the intrinsics of our foot. So this is kind of looking again at that valgus versus varus again. We covered that yesterday. I'm not going to go back into that. And then going from normal to pes planus or flat foot. We have our muscle functions, right? We have our plantar flexors, our main plantar flexor being our gastroc, and then our soleus being our really support one, again, being the strongest muscle by volume in the human body. And then we also have some secondary plantar flexors, tib post, flexor hallucis longus, flexor digitorum longus, peroneus longus and brevis, all help with plantar flexion. But again, they really don't kick in unless we've got problems with the gastroc or the soleus. With dorsiflexors, our primary one obviously is tibant. That's the one that handles most of it. And when you get a paralysis or a problem with that tibant, that's where you get into some major problems with clearance of the foot. The extensors of the foot can help a little bit, or extensors of the toes, but not a lot. And we have those intrinsics, interosseous, and the lumbricals. And then when we're talking about stability, when we talk about stability in standing, meaning our balance, right? During standing, the gravity line, which is the line that runs through the middle of us, should fall anterior to the axis of the ankle joint. Meaning if we were to draw a straight line that came down through our body, where it intersects the floor, should be kind of right in front of where our ankles are in order to have a good, proper balance. The soleus is our primary anti-gravity muscle. That's why it exists, and that's why it's so strong, is because it helps keep us when we're kind of rocking back and forth. It's one of our major stabilizers in our ankle. When as far as gait goes, I gave you all of those muscle actions during gait on that gait lecture. I'm not going to rehash all those again. But again, most of the time with all the muscles in the leg, when we're walking through gait, all muscles are going to have a concentric phase, an isometric phase, and an eccentric phase, where they're doing a little combination of all three, right? We can actually do some eccentric with some isometric hold. So they all of them, even the intrinsic foot muscles come into play when we're walking. Some common kind of nerve pain injuries. Common fibular nerve, right? Lateral fibular head, neck is where we can end up with that problem with the fibular nerve. That's up towards the superior portion of the lower leg. Posterior tib gets impinged a lot of times at what's called the tarsal tunnel. If we have the carpal tunnel in our hands, we probably also have the tarsal tunnel on our foot. And that is just kind of backside of that medial malleolus. And the reason it's called the tarsal tunnel again is because in that area, we've got nerves passing, blood vessels, more nerves, more blood vessels. And so it develops a tunnel that looks a lot like that median nerve tunnel in our palm. Calcaneal and plantar nerves, typically we end up with problems down in the bottom part of our foot if we do overpronation. So for one of those people that really highly overpronates, we can end up with some nerve pain in our toes because of that. And which is why, again, we're going to try to convert them to more of a neutral runner. And then the big problem that I've actually seen more of than anything is what's called a Morton's neuroma. And so a neuroma, by its definition, is a growth on a nerve, right? Neuroma. And we always think oma as being cancer. It doesn't necessarily have to be cancer. It can just be an abnormal growth. And some of you may have a Morton's neuroma and not even know it. But a Morton's neuroma typically occurs in the space between the toes. So just back kind of at that MTP joint, so that metatarsal phalangeal joint. If you can take your fingers and kind of go in between that space and pinch, and you get a really, really sharp pain or a pain that starts to radiate to other parts of your foot, you may actually have a Morton's neuroma. I have one in my left foot. I know I do, from way back when I had problems with my big toe and bashed it all up. I got some growth growing on that little kind of nerve that's in there, and I've got a Morton's neuroma there. Does it cause me problems? Not really. I mean, as long as I don't pinch it, I'm okay. But if it, for whatever reason, should overgrow, right, and keep growing, because that's what tumors do, right? If that should overgrow, that can cause major problems that every time I'm planning down, I'm irritating that nerve, and my big toe may go to sleep, or maybe my second toe may go to sleep. I don't have that. But if you go through your foot and you kind of pinch between your toes, and you find one of them that's really super sensitive, especially I've seen a lot of it between the third and fourth toe. You encounter that, then you may have a small Morton's neuroma in there. And again, not a huge deal, but it's just something kind of monitor, just like any other OMA, right? If we had a hemangioma, we'd monitor that as well. Sensory reference in the foot. So dermatomes of the foot are primarily L4, L5, S1. You learned that back in anatomy, right? So if you have pain down there or nerve issues down there, a lot of times they may stem from those parts of the nerve, so the lower portion of the lumbar section and the top of the sacral section. What causes injuries to the lower leg? The number one thing that causes injuries to the lower leg and the ankle is repetitive motion or overuse injuries, right? Where people just don't allow an injury to fully heal. It's very common in athletes where they'll sprain their ankle, they'll stay off of it for a week or two and then go right back to sports. And when they go right back to sports, they re-injure the ankle again. And then again, it's just like any other structure in the body. If you injure it once and then you injure it again, it gets easier and easier to injure, right? Traumatic brain injuries are a great example of that. If you get a traumatic brain injury, it's more likely you'll have a second one in the future, which will be more likely to have a third one in the future. Same idea here. If you keep injuring that ankle, it's going to make it more susceptible to ankles. Does anyone in here actually have, I know from last semester we had a student that literally like could look at his right ankle and it would sprain. Does anyone in here have kind of ankles that are kind of weak from repetitive injuries? So Anthony, from basketball, maybe Anthony? Yep, that's what I figured. The same idea with the student from last semester is, and ironically enough, the very first week of his program last time, he had his whole walking boot on because he ended up spraining it. And Amanda says, yeah, well, Amanda, I'm just saying, like, you were in the military, that kind of predisposes you to every injury. I'm just saying. And skateboarding, yeah, Truman, that's kind of where mine are really torn up. You wouldn't think I was a skateboarder looking at me, right? I don't look exactly like skateboard material, but I am no stranger to skateboarding. I actually have one in my closet still that I use to go get the mail and stuff. So I do not look like your typical skate or die guy, but definitely still a skateboarder. I don't like the skateboard I have in my closet because it's a newer Birdhouse skateboarder and they're too skinny. I like bigger, fatter boards. Basketball is the beginning of the problems. Yep. Right, and it's funny when you think about that. I mean, your comment that you made there, right? Break those ankles. It's kind of funny that we use that as a term in basketball and football and that, right? When in reality, what we're literally doing sometimes when we make those cuts is break those ankles. You can injure somebody else's ankles pretty easy. Joint hypomobility at the ankle, a lot of time. Oh, I thought I saw somebody popping in. RA is a big one, mainly in the forefoot early, so up in front of the foot and then leading back to the hind foot. DJD and joint trauma happens, degenerative joint disease. So the more ankle sprains you have, right, the more likely you are to end up with any form of sprains and stuff like that, and then leading to degenerative joint disease down the line. Does anyone know what CAI is? What bone is C in the ankle?
Calcaneus.
Yeah, there we go, right? Calcaneal ankle instability, you'll see it often, which means that talar crew or the calcaneal talar joint is not as stable as it should be. And again, any fractures we get at the ankle just leads to more problems down the lines. Post-immobilization stiffness, if they've been in bed for a long period of time. And the other one that I encounter here in Vegas, for whatever reason, a ton, is gout. Where's my little drawer? It's over there. I encounter, for whatever reason, I've had more gout here in Vegas than I had ever in Pennsylvania. And I don't know why. I wish I had an answer for that. Unless it's just, I mean, there's some link to it. It is influenced by dehydration. Yep. It's also influenced by beer and also eating processed meats. So like your like lunch meats and stuff like that. Red meat, not so much, Anthony. But if you get like the top round, yeah, Spam, yep. Like top round that you would get at the deli counter where it's kind of been pressed and squeezed together, that can definitely contribute to it. Brittany, that actually is a really good question. I don't know that seafood contributes. I'm actually going to look that up. I'll look that up on the next break. I don't know.
I know shrimp is really bad.
Well, that makes sense,
For
but
gout.
shrimp's like
Any,
really bad for everything.
Yeah. And then
I'm just saying.
I think shellfish, period. I don't know. That's what my doctor told me to stay away from.
Yeah, that's a possibility. I just don't know, so I'd like to. I'm going to look at soy sauce. Probably would because of the dehydration. Unless shrimp's farmed up slave labor. Yeah, I mean, unless you watch what's the show that's on Animal Planet, Lone Star Law, when you get to see all the people down there shrimping off the coast of Texas. It's a great show. But it's a buildup of uric acid, right, in the bloodstream and also in the joint spaces. And a lot of times it develops in the big toe, but it's not limited to the big toe. Gout can occur anywhere. Yeah, Bianca's missing out on gout. I'm telling you, we have to treat her to it. Just joking. I don't think I'm missing it, Bob. Let's see if anyone gets that reference. I actually had a patient that actually had gout of the knee. And he said that was the most miserable experience he ever had. Just imagine, like, if any of you had gout of the toes, just imagine we got an office space. Good, I'm glad. Just imagine getting inflammation in the knee that's just because there's too much uric acid crystals in the knee. And he was just miserable from that. He couldn't walk on it, couldn't bear weight. Structural impairments, activity limitations. A lot of times, the main thing that causes us problems at the ankle joint is swelling. And if our ankle is swollen, what is our ankle trying to tell us?
To get off of it.
Get off of it, exactly. That's 100%. Rest it. Yeah, right? I mean, that's chill out. Yeah, that's the main thing. And that's something we miss a lot of times. Oh, it's just a little swollen. Well, if it's a little swollen, it's telling you to get off of it, right? Now, does that mean that someone like me, if I work a whole day, like if I'm doing security and I'm on my feet all day long and I come home and I take my shoes off and I take my socks off, my feet swell a little bit because I've been on my feet all day, right? That's not necessarily the same as spraining my ankle and getting true kind of edema swelling in that foot. When we're looking at those problems in the ankle, in the protection phase, the main job is to decrease pain and decrease swelling. Well, why is that? Because if we can decrease pain, decrease swelling, we can get further along in getting that repaired. And again, in that protection phase, we're going to maintain our joint ability. So the ability to move, the soft tissue extensibility, and a lot of passive range of motion. And then as we get better, we're going to start increasing the joint play, start allowing other motions like rotational motions, inversion, eversion, work on maybe some joint mobs if it's a capsular pattern. Improve tracking the talocrural joint by increasing plantar flexion, dorsiflexion. We can do mobilization with movement, and that's a unique kind of mobilization that we'll talk about. I'm not very good at this, but what they can do is when you're moving through plantar flexion and dorsiflexion, we'll do joint mobs while you're doing it in order to increase the joint play or the space in that joint so that it increases movement. It's a whole like continuing education theory that goes along with that of, well, maybe we shouldn't just mobilize joints while they're in open packed position. Maybe we should try to mobilize joints the whole time they're moving. And there's a whole skill to that. And some of it I've read some good information on. Others, I'm just like, there's not enough information on this yet that it definitely is a good thing. But it exists out there. And I've seen more mobilization with movement in the ankle than I've seen anywhere else. When we have ankle problems, the number one thing we usually lose is balance because the ankle is so important to our balance. So we've got to work on recovering balance once we get injured and get back to that return to function phase. So what kind of surgeries can we have? Well, we can do a total ankle arthroplasty. And I'm going to put behind this, this is very rare. I can count on no fingers how many times I've seen this because I have not seen one yet. Indication will be 65 or older, lower BMI, low pre-surgery ankle injury, sedentary lifestyle, anything like that can lead to this. Problems with this is they get chronic infections or instability of the ankle, can lead to problems with the surgery. This is kind of what it looks like. I found a picture of it, but again, I have never seen a total ankle arthroplasty. But what they're going to do is replace that distal end of the tibia and the superior aspect of the talus, and basically do the same thing we do at the knee or the hip and increase the range of motion. Now, if your tibia or something's breaking down, it makes sense to me But again, I've just never seen anyone get this surgery before. I just want to cover it because the book says it exists, but I have never seen it. I have seen these though, arthrodeses. Again, arthro meaning joint, desis meaning fusion. The main reason I've seen these, and you guys probably won't see this at all, is from polio. Why won't you guys see this as much anymore?
Polio's eradicated.
Yeah, polio is pretty much eradicated at this point, thankfully. Although, to Joseph's doesn't exist in America anymore, some anti-vax moms are trying to bring it back, you know. I had a discussion with somebody on Facebook a couple weeks ago. Yeah, so Riley says his mom and uncle had exactly, right? And did they have early onset polio maybe?
No, they didn't actually. My uncle was a football player and my mom was walking across the field and snapped all the ligaments in her ankle.
How that just hurts thinking about it. Like, I mean, football player I can understand, but the snapping of the ligaments, oh. Yeah, so I had an interesting discussion with some lady the other day. It's like, well, you know, I don't know why I have to vaccinate my children. I've never seen polio and I've never seen pertussis ever in my life. Well, the reason why you've never seen pertussis and the reason why you've never seen polio is because we vaccinate people. Mr. McKeever's head explodes. But yeah, polio used to be what they called the great crippler. Yeah, science, exactly, right? Science does not talk about reading your Facebook group. I'm just saying. Polio used to be the great crippler of young people. And if you would go to there's still some areas that are polio endemic, meaning there's still polio there. Afghanistan's one of them, Pakistan's another, and then some countries in sub-Saharan Africa are also still polio endemic, meaning it still is there, it's still prevalent, and there are many reasons behind that. I could go into that. Like in the Middle East, they actually will kill the WHO workers that come to give polio vaccines because they're saying they're coming to sterilize people. Seems like we've heard that here in the United States too. I used to have iron lungs. Yep, exactly, Daniela. And that also came along with pertussis and TB as well, right? But it's amazing. I actually have a close family relative that had polio. What I guess has polio. It's a dormant now. And I'm not joking when I say that, you know, his ankles are smaller, or his legs are smaller than my wrists. They basically have just wasted away to bone. And he gets around with double forearm crutches. And it's not a fun disease, right? When we do arthrodesis the ankle, we can fuse the ankle itself, meaning just at the talocrural up here, right? We can fuse the hind foot, or the big one I've seen most of the time is this triple arthrodesis. So they fuse the subtalar joint, the calcaneal cuboid, and the talonavicular. And that's probably what I'm guessing Riley's mom had. It's one of the more common ones. And basically, if you look here, these are all the fusions of it. They put that nice long screw the whole way down through that calcaneus and the talus. And they have all the little itsy bitsy screws all over the way. They're gonna fuse them slightly in dorsiflexion, so about 5 degrees of dorsiflexion for foot clearance. But again, once it's fused, that ankle is not going anywhere, right? You can't mobilize it. It's screwed together basically, right? You can do arthrodesis of the first toe, also the IP joints of the toes if needed. Here's one where they did a lot of fusion. So this is a triple arthrodesis, and I think they also fused some of the mets as well. But what can happen with this? Well, obviously, after the surgery, they're going to be immobilized for a while, which is going to lead to all kinds of problems and complications there. Most of the patients I've seen that have had triple arthrodesis or even just simple arthrodeses usually are non-weight bearing for up to 9 weeks. So they can't put any weight on that foot for 9 weeks, which then causes muscle fatigue and muscle atrophy and stuff like that. And then we've got these post-operative exercises we're going to need to force them to do. But the problem is we have to remember that they may not have inversion, eversion, plantar flexion, dorsiflexion. So the only thing they can really actually work is their toes. So we'll work a lot of stuff where we're working those intrinsics of the toes and stuff like that. And my office is warm today. Short-term goals on that, now long-term outcomes on that, obviously, is to increase the stability of the ankle. And we're only going to do that in the case of, like Riley said, where they've torn most of the ligaments and that ankle can no longer support itself. But it's a pretty nasty surgery when they do stuff like that. Deformities of the ankle we can get is either pes planus or pes cavus. So either flat foot or claw foot are the two terms you usually have. And usually pes planus is congenital, meaning it kind of travels down family lines. That if your dad had flat foot, you might have flat foot type idea. It's not necessarily 100% hereditary, but I've seen it where you can look at whole families and the whole family has flat foot. A lot of times it's due to the intrinsic weakness of the foot and laxity of the ligaments that support the arch. Pes cavus is that big claw foot, like I said. It can be a neurogenic pathological process, meaning those intrinsics of the foot become spastic, and that can lead to it. Muscle imbalances, anything like that. The treatment at that point is to reduce pain and overall try to flatten that foot out. So we're going to work a lot of stretching out the base of the foot and working on the plantar fascia. Hallux valgus, or a bunion, is a deviation where the great toe kind of shifts. It's usually exacerbated by poor footwear, so shoes with narrow toe boxes. And I've got a really, really wide toe box, and I have to be careful when I order or I get shoes, because if I don't get a shoe that has a wide toe box, I oftentimes end up with a lot of pain out here on that kind of medial aspect of the big toe, and it can develop into a bunion, because what it's doing is it's forcing my big toe into my other toes. So we'll modify the footwear, and we may actually do some range of motion on the toe, or we may put a spacer in here between the toes to kind of separate them out and move this toe back out. If it becomes pathological where we actually get a bony growth out here because of it, they'll go in and they'll literally just cut that off and do a bunionectomy and just cut that kind of chunky part of the bone off. But again, anytime we do surgery on bones, it weakens them. So we have to be careful with that. Heel pain. What can cause heel pain? Plantar fasciitis is the major one because the plantar aspect starts near their heel. Achilles tendinopathy, Achilles tendonitis, and then tendonesis, tendonitis, or tenosynovitis when we have intrinsic muscles of the foot. Shin splints or medial tibial stress syndrome. MTSS is the preferred term when we're talking about it in the physical therapy world, but you can also, obviously colloquially use shin splints with your patient. It's usually if we have anterior shin splints, meaning primarily on that anterior lateral side, it's overuse of the TA. The pain will increase with active dorsiflexion and passive plantar flexion. So actively, when you pull the toes up, it hurts. And if you stretch down where you're stretching that tibialis anterior out, it hurts. Posterior shin splints can be kind of posterior and medial. It's usually caused by a tight tricep surae, right? So gastrocs and soleus. So if you dorsiflex or you stretch them out, they'll get pain. And if they get active eversion or supination, it increases the pain as well. For all of those, the only thing we can really truly do to treat them is rest. And you have to rest, or otherwise, like I forget who said that yesterday, they can end up with microfractures of the shins. So they've got to rest, they've got to ice it, let the body heal a little bit, and then also address what might have been causing it, whether it's bad foot, poor footwear, maybe you're running on a bad surface, you're out running in the woods with rocks and everything like that. Ligamentous tears we talked about yesterday, right? The number one tear is kind of that inversion sprain is the number kind of one tear we have. They can be recurrent or recalcitrant, meaning that they just keep coming back because, whether it's the ligaments themselves become lax or the articular cartilage that holds everything together becomes lax or the synovial membrane becomes ruptured. The more ankle sprains you get, the more likely you are to get ankle sprains. If you untreat them, meaning you don't do anything for it, you sprain your ankle, keep walking on it, it's going to lead to chronic pain and muscle weakness of the ankle. That's why rest is important. And the other problem that can happen at the ankle that, I've seen a couple of these are ruptured Achilles tendons. And usually when I see a ruptured Achilles tendon, a lot of times you're going to see this term, avulsion. Does anyone know what avulsion means?
Isn't it?
Oh, go ahead, Anthony.
I'm just gonna guess here. Isn't it when the tendon breaks off a piece of the bone? and there's a
Yes.
fracture?
Yeah, so if we have our calcaneus back here, right? When that tendon rips off, it pulls off a piece of the bone with it. Right, and I've seen them literally where that tendon, that calcaneus tendon has ripped off and it rolls all the way up here up in the upper part of the leg and pulls that bone with it. So you can obviously cause all kinds of complications there. They'll refuse it, but once that bone's kind of pulled off, it's not like we can necessarily put that piece of bone back. So they're always going to have that little chip of the bone gone back there. But most of the Achilles tendons I've seen have been minor ruptures, meaning partial tears. But if it completely tears, that can end your sports career. And there have been a couple athletes where that's happened, where the Achilles tendon ripped right off the bone, and that's the end of their career. They're done. They're in the booth broadcasting.
I have a question. I saw in the clinic before some guy had ruptured his Achilles tendon, and he said that he opted out of surgery and he was just doing like physical therapy. Is that a treatment for a full rupture?
Well, if it's a full rupture, I doubt it. He must not have had a full rupture. That's the only thing I can figure out, because if it's fully ruptured and pulled off that bone, I mean, you've lost a gastroc.
Right.
So I'm guessing it was either maybe a 3/4 or less rupture where he still had some tendon down there. But I mean, I've never seen somebody with a full rupture that skipped and just went physical therapy because you've lost dorsiflexion.
Yeah, because he was
Or plantar
saying,
flexion. Sorry.
yeah, the treatment was going to be like super long with the PT regardless. So.
Yep. And Joe asked, does the body dissolve chip bone? It absolutely does. It may take time, right? Just like anything else. Same thing can happen if you get like bone spurs in your heel or your foot. The body will eventually reabsorb those. Most bone spurs resolve pretty fast. So, you know, you don't need to get deferments for going to war or anything like that if you've got bone spurs necessarily. You may need it for a couple of weeks. Most of the time they do resolve. But yeah, the body will reabsorb them. Okay, Joe got my joke. I appreciate it. I got to see a couple smiles.
I also got a question. So I don't know if you kind of talked about this already, but I've heard of like a procedure called like the tightrope procedure. It's on the ankle.
Okay.
Usually, but what does that usually do for your?
Let me look. I'm actually not so sure about the tightrope procedure, but let me just take a peek. I can look real quick. Maybe I can explain it once I figure out what it is.
I think it's like fixation for I think it's for like ankle.
There's tightrope ankle surgery. So it's fixation. Okay. So it's fixation of the syndesmosis. Okay. I don't think I've ever seen this. Oh, hey, it ties right into what we're getting ready to talk about. High ankle sprains, evidently. I've never heard of it, believe it or not.
They do that usually for like football.
Yep. Yeah. So we obviously talked about ankle sprains already, and so we have our classifications here. We didn't talk about. I'll talk about the tightrope once we get down to that high ankle sprain. When you have a first-degree rupture or sprain of the ankle, it's a single ligament. Second degree is 2. Third degree is typically 3 lateral ligaments that are torn. That makes sense because 1, 2, and 3. We'll talk more with soft tissue injury what a grade 1, grade 2, and grade 3 sprains and strains are. But for the ankle, when you tear 1, it's a first degree. When you tear 2, it's a second. And when you tear 3 or more, it's a third. High ankle sprains are a kind of a misnomer. It's a syndesmosis strain. So that means that up here in the syndesmosis joint is where the actual sprain occurs. It's considered a high ankle because it's not down here. So he had mentioned about a tightrope surgery, which again, I had not heard of, but I just looked up and I understand what they're doing. Right, tightrope surgery is a surgery they do for pretty extreme high ankle sprains. A lot of times football players get it, like you said, especially wide receivers, right? Because they're landing and spinning and jumping and all that fun stuff. Usually, I've seen high ankle sprains are diagnosed by this external rotation and squeeze test where they'll turn the foot outside and squeeze the high ankle. And if they've got a problem, it will be super painful, like screaming painful. They can do x-rays as well and stuff like that. What they usually do with this tightrope surgery, and I didn't know that was what it was called, is they come in here and they're going to put a pin that goes kind of across that tibia and fibula that pins them together. So I have a point over here and a point over here that locks it in place. And that makes this syndesmosis joint a lot more stable, but it's also going to reduce overall ankle mobility as well. But for somebody that's got recurrent high ankle sprains, it's kind of important to stabilize that so they stop getting it. Because what's happening literally is that tibia and the fibula are shearing on each other. I know that, now that you mention it, I didn't know that was what the surgery was called, but I know that like Julio Jones from the Falcons had that surgery. Well, he's not in the Falcons anymore. I guess we traded him away for a 2nd-round draft pick. What were we thinking? Hey, he's with the Titans now, thankfully. Yeah, great. Good job, Atlanta. Trade away your #1 receiver. Anyway, not bitter at all. But the idea there, and evidently also, because I was looking at some of the other pictures, they can also put another, if they need to, another screw kind of higher up the leg if it's still not stable enough. But remember, anytime we start adding hardware, we start adding increased chance for infection and also increased loss of, yeah, Oscar's like, maybe not yet. Increased loss of motion, right? So that's what evidently it is. I did not know it was called that. I knew that there was a surgery for pinning it. I just didn't know what it was called. So now you taught me 2 days in a row. I've learned something. How about that? You guys even teach me. There's all those fun ligaments of the foot. I'm not going over them again, right? Just remember that when we're talking about them, which ones sprains, the medial, right, ligaments are going to be sprained in an eversion. The lateral ligaments are going to sprain in an inversion sprain.
I did have a quick question for the deltoid ligament.
Yep.
So it's basically like a set of ligaments, but we call it deltoid ligament.
Yes. Yeah, it's a group of them. Right.
Okay.
And again, I'm going to say it most of the times lately, I've not even heard it as deltoid. I've been hearing it as kind of the medial ligament or the medial ligament set. So it just depends upon the book you're looking at. I understand why they called it deltoid ligament because it looks like a deltoid. I mean, look at that. It looks like your deltoid muscle. So again, more ligaments. Congratulations. I did want to cover this compartment syndrome because this has been a topic that we've run into a couple times in the clinic that I've had students message me about going, I don't understand what compartment syndrome is, Mr. McKeever. Compartment syndrome can occur anywhere in the human body where there is a compartment. So you can have compartment syndrome of the forearm, right? I've seen that in hand therapy. Compartment syndrome of the upper arm, compartment syndrome of the stomach, compartment syndrome of the legs. Usually when we have compartment syndrome, it's mostly occurring down at the lower leg. And we actually had a student 5 cohorts ago, I don't remember, that actually ended up with compartment syndrome, not while she was in school, but before from cross-country running, where she had repetitive MTSS and didn't treat it. And her coach just made her run through the shin splints and ended up getting compartment syndrome because of it. And what happens is you get increased or elevated chronic pressure within a closed fascial space. So again, when we get pressure increasing, the only thing that can happen is stuff starts getting squished. And when stuff starts getting squished, it cuts off blood flow. It also then cuts off, flow for the lymphatics and stuff like that, and will end up actually damaging and killing tissue. It can happen with tib fractures, muscle rupture, muscle hypertrophy, or burns is the main reason I've seen it. Yep, go ahead, John.
Is the pressure coming from like the bone itself or like swelling?
It's coming from swelling.
Okay.
Yeah, so like if I have anterior compartment syndrome, right? So it's because this is what the student had, so I can kind of use this as an example. So here's my anterior compartment, right? She had MTSS here in the syndesmosis. And because she had MTSS, it caused this whole area to swell. Well, you can only go so much out. Can happen post-surgery. Sure, Amanda. Yep, absolutely, right? You can only go so much out before that leg just won't expand anymore, right? So at that point, the only way it can really swell is by going in. And so her leg gets swollen. She actually, I wish she'd let me keep the pictures, but she said it was only valid for her cohort. But her leg, so she had a really kind of tiny lower leg, but literally her leg looked like my thigh when it was swollen. It was just huge. It was like, I think she said it was like 28 inches around in the lower leg. And it couldn't expand anymore out, so it started squeezing in. And when it started squeezing in, her tibialis anterior started dying. And so we've got the 4 compartments. We get the anterior, the lateral, and the posterior compartment, and then this deep posterior compartment. So what they notice is she had pain, palpable swelling, tenseness, and she started having numbness of the foot, and then the skin got warm and shiny. And what warm and shiny indicates is that those lymph vessels have kind of pushed as far to the surface as they can go, and they can weep. So literally, she had weeping going down her shin where she had just fluid kind of seeping through the skin. The only thing they can do at that point is what's called a fasciotomy. And she had this where they went from all the way from her tibial crest, from tibial tuberosity all the way down to her ankle and made 5 incisions going right down the front of her leg. And when they made that incision, all of that lymph fluid, that edema, just literally seeped out through those incision sites, and they left them open. So the fluid kind of got released. Usually they'll do it if they don't do it within 12 hours, it can literally kill off all the tissue in that leg. It reduces the intercompartmental pressure, and they'll have a sterile dressing over it to kind of absorb the fluid. But they do want those patients walking. You would think it'd be kind of counterintuitive, but as they walk, it helps those lymph vessels pump a little bit more, which causes the fluid to seep more. And then after about 2 or 3 days post-op, they'll close up those incisions to test to see if the actual body starts returning kind of a normal shape. And you're left with kind of nasty scars down the front of your calf. There's one girl that I saw that had the compartment syndrome in her forearm, and she has like 3 really nasty scars going down kind of that posterior aspect of her forearm, because that was where her compression syndrome was, or her compartment syndrome. But it can be a limb-threatening condition. And this student that I was talking about actually had it in both her lower legs. So she had to have fasciotomy on both her lower legs, which was, she told me it was just terrifying, because they said, well, if we don't do this, you're going to lose your legs. And so she's like, well, then do it. I can understand that, right? If you told, well, you either do the surgery and leave your wounds open, or you lose your legs, pretty confident I would have the surgery too. I don't know about you guys. But does that make sense for at least what compartment syndrome really is? That it's really a chronic swelling condition that cuts off all of your blood flow and really compresses down on your compartments of your limbs. Right? Makes sense, okay. We talked about the fractures yesterday, right? We talked about you could have a lateral malleolar fracture, medial malleolar, bimalleolar, or trimalleolar fracture, depending upon what you're looking at. It's going to be treated with immobilization surgery and then a walking cast for several weeks afterwards until the patient actually has kind of a fixed bone at that point. Whenever we're talking about flexibility or stretching, right? If I need to increase my dorsiflexion, I have to stretch out my plantar flexors. If I need increased plantar flexion, I need to stretch out my dorsiflexors. You need to stretch out that antagonist muscle that's limiting you. All of these areas you can stretch into dorsiflexion, plantar flexion, inversion, eversion, or combination. We will work on some passive activities and some active activities for the foot come our lab days. But the main idea for the foot eventually is, as much as we stretch it, as much as we work it, is this development of neuromuscular control. The foot is important for gait, right? The earlier we work on getting back to normalized gait with, heel strike, roll through, toe off, heel strike, roll through, toe off, the more likely they are to get back to normal gait. Because if I have an ankle injury, or I have a high ankle sprain, or I have a fusion of my ankle, I'm going to start developing bad habits. And we know, all of us know from experience, bad habits are hard to break. Like right now, one of the bad habits I'm trying to break is sweets. It is extremely hard to break myself of eating like baked goods. So if we develop bad habits post-surgery or post-injury, they're really difficult to break. So we got to get those patients back to kind of normal gait patterns as soon as possible so they get back to a normal functioning life. We can do open and closed chain of pretty much everything, right? We can do plantar flexion, dorsiflexion, all ankle motions. We can do ankle rotations, right? Which is just rotating the ankle around in circles. Has anyone seen people doing ankle alphabets for those of you that are techs in the clinic? Right? Ankle alphabets are where they're doing the ABCs with their ankle. I like to, Riley says dance. Yeah, they're really actually popular in dance and gymnastics, I found out. I didn't realize that. But it makes sense because you have to have functional ankles to do both of those, right? I like to, because my patients always ask me, well, do I do uppercase or lowercase letters? I'm like, do it in cursive. And then like kids will stare at me and go, what's cursive? Anyway, but yeah, it doesn't matter if you're doing uppercase, lowercase. I always find that uppercase is more challenging for the patients because they have to think about it. But yeah, so ankle alphabets, we can also do those ankle alphabets or the rotations in what's called a contrast bath. Does anyone know what a contrast bath is?
Like hot, cold, hot, cold, hot, cold.
Yeah. So we have 2 buckets, right? So here's bucket 1. And because I'm awesome with colors, here's bucket 2. Right? So we have cold and we have hot, right? So cold and we have hot. So if I have an injury, or say I'm treating Truman, right? He's got an ankle injury. He's got swelling in that area. A lot of times what I'm going to do to start with is I'm going to start putting him in a warm bucket, because what I want to do is kind of loosen up that's not only all the structures in the joint, but also kind of thin out that fluid that's in his joint. So I'm going to put him in there. I'll have him doing some ankle alphabets or something in the hot water. And then after I have him in that, maybe for 3 minutes, then I'll swap him and I'll move him over here to the cold bucket. Why would I move him over to the cold bucket? What's that going to do?
Reduce inflammation.
Right. Yeah. So it's going to all the things that cause reduced inflammation. So everything's going to kind of contract up, right? We're going to get that vasoconstriction going on. So all that fluid's going to be pushed kind of out of the ankle, right? So it's going to be pushed up to the lower leg. Hopefully it returns to the heart and gets out of the body. It doesn't just return to the ankle if they've got chronic lymphedema. But so now he's over here for 2 minutes, right? So he's over here for 2 minutes. He was over there for 2 minutes. And then we're going to put him back over here for 2 minutes. And a lot of times we'll do this for about 8 minutes straight, where we're swapping back and forth between them. And the idea is to cause the ankle to expand a little bit with the heat and then contract with the cold and pump the fluid out of the ankle. It's not only of the ankle. You could do it with the wrist too, or the forearm. You could actually do it with the whole leg if you had something big enough. You could do it with the whole body if you did like something like jumping from a hot spring into a cold spring or something like that. But I don't know why you do that. Cause your heart attack. But yeah, so a lot of times I like using contrast baths with my ankle patients because it really does tend to reduce swelling in that ankle. Truman, did you have a question? I saw you pop up there for a second.
No, that was just an accident.
Okay, just making sure. So if this helps us increase our mobility, then our closed kinetic chains are going to help us increase our stability, right? So we're going to do a lot of activities where we're bearing weight down through that ankle and maybe rocking back and forth, rocking laterally, work on some dynamic strength training activity in that, where we're doing maybe some BAPS board, which are the resisted board for rotations, some resisted walking, and then just work on functional progression, right? So if the patient has good heel strike, great. The next thing we'll work on is kind of the roll through, right? So we'll work on the roll through, where they're rolling through the whole foot to get to toe off. And then once they get that roll through done, then we'll work on toe off. And then once we've kind of worked on all that, we'll work on the whole combined group. So breaking it down for that parts to whole kind of training is really good for the ankle. And then once we've got gait, we may progress to going up and down stairs or going up and down ramps, walking backwards. All of that kind of improves the overall muscle function of the ankle. All right, so that's it for the ankle. Let me bring up our balance lecture. So it depends. So great question. Anthony asked, do we always work on mobility first or stability? No problem, Stephanie. Most of the time, and this is kind of a good rule of thumb, is that you can't really have stability can't really have mobility until you have stability, right? But because of the way both the knee and the ankle work, a lot of times we kind of reverse that and work on more open kinetic chain activities before we get into the weight-bearing closed kinetic chain activities. So I would say that the knee and ankle are kind of the two exceptions to the rule. Most of the other stuff, we're going to work on stability first and then go to mobility. Like the shoulder, especially, I work stability before I ever work mobility. I want the shoulder nice and solid before I get them doing stuff like throwing a football or something like that. Does that make sense, Anthony? Again, like I said, most of the time it's the ankle and the knee that's kind of the weird one.
Sorry, did you say that was like dependent on, I kind of missed it. Dependent on like the surgery type, or?
It can, for sure. Yeah, right? Like in the example of the ankle, if I've got a fusion, well, I've got no need to work on stability at that point. That ankle is fused. So the only thing I can really work on at that point is mobility. But for the most part, what I said was that in the ankle and the knee, they are kind of the oddballs out of the human body joints because they are primarily weight-bearing surfaces.
Okay.
And so a lot of times we're going to work open kinetic chain activities, which are typically more mobility-based, if that makes sense, before we get to stability. But everywhere else, like the hip, I work stability, meaning isometrics, resisted isometric, stuff like that, before I ever get to mobility. So it's just that ankle and the knee, and even the wrist, I would say, is probably another one that I would say is kind of the reverse of our thinking for everything else. Yeah, I usually do stability before mobility in most of the joints, except for probably those three joints. All right, so tying into the ankle, we're going to talk about balance now. Yay, this is probably, I'll be honest, when I'm working in the neuro field, this is about probably 80% of what I work on is balance. Because almost everyone that is 65 or older, or even I'll say a 65 or younger, have balance problems in some way, shape, or form, and we can improve balance. So some quick terminology with balance, right? Center of mass is the point of the body where it's in perfect equilibrium. So it's the point where your mass, you could literally, if you could stick a stick through you, you could rotate around that center of mass like you're on a, what do you call it? A skewer or something over a barbecue. Rotisserie, thank you. There's the word I was looking for. I appreciate that. Center of gravity is the vertical projection of the center of mass to the ground. So that vertical gravity line, which we talked about before, passes through your center of mass and aligns with the center of gravity. Center of pressure ties to ground reaction force, which we'll talk about in a second. But it's kind of where you're going to put most of your pressure. So if I'm standing on 2 feet, I have 2 centers of pressure going down through the middle of my foot, usually about at my first met head in that region. If I'm standing on 1 foot, my center of pressure is only going to be somewhere in that foot. Momentum is our mass times our velocity. That goes back to physics. Yay. Base of support is how we kind of stand, right? The wider our base of support, usually the more stable we are. The more narrow we make our base of support, the less stable we are. We all have limits of our stability. Right now, when you're sitting in your chair, you have limits of stability, right? I can lean so far this way and my muscles can control me, but eventually I'm going to hit a point where my muscles can no longer control me and I'm going to fall out of the chair, right? We've all seen this with either a friend or a baby or a kid where they're like, I'm not tired. And they're sitting there and they're like, I'm not tired. Or maybe we've done it ourselves. And all of a sudden you lean forward and you're out of that limit of stability and face first. The ground reaction force is part of Newton's law of every action there is a reaction. So if we push down on the ground with 1,000 newtons of force, the ground is going to push back at us with 1,000 newtons of force. If not, the ground may give or we may give, depending upon the force. Base support we talked about again. How about that? That's why do I have it on there twice? Because I'm an idiot. Coordination. When we talk about coordination, we usually talk about either agility or dexterity. What is the difference between agility and dexterity?
Is dexterity more like fine motor and agility gross motor?
Okay, it's a good theory. No. When we talk about in physical therapy, dexterity is what I'm doing right now. I just wanted to pick on you. That's all. It's the first time I could do that to you. Dexterity is what I'm doing right now. So dexterity is typically use of hand-eye coordination. Agility is typically thought of eye-foot coordination or coordination of lower extremity movement. So that's typically what so when you talk about agility drills with a patient, it usually means you're doing a lot of cutting and running and jumping and stuff like that. Whereas if I'm doing dexterity drills, I'm doing stuff like this, where I'm getting them to control stuff, figure out where the ball is going, right? Juggling. I only have one, so I can't juggle. That type of an idea. Does that make sense?
Yeah.
I got two. There we go. There we go. So that would be a dexterity drill doing that. We talked about these mechanoreceptors before. It must be really hot out. My air conditioner keeps coming on and off. GTOs are the Golgi tendon organs, right? These are designed by Pontiac. No, I'm just joking. GTO, get it? Anyway. These are located in your tendons themselves, and they're responsible for conveying information about muscle tension and length. And then you have your muscle spindles, responsible for information about muscle length and rate of change primarily. All of those tie into our neuromuscular control and postural equilibrium. Anytime that we are sitting, right? Equilibrium means that we are in balance, right? When I am sitting here, I have postural equilibrium. Riley could have gotten mad at me after my last little joke with her and smacked me upside my head, and that would challenge my postural equilibrium, right? She'd give me a good old Gibbs slap in the back of the head. I can then use my reaction and my base of support to keep myself from falling out of my limit of stability, or if she smacks me hard enough, I may fall out of my limit of stability and fall out. I'm going to use my proprioceptors, my awareness of where I am in space in order to determine what I need to do to keep from falling out of my chair. So how do we kind of work on our sensory system? Well, we use our vision. Our vision is a big part of our balance, right? Does anyone in here get motion sick or seasick? Yes, Christina says, yeah. I only get it when I'm on the, like I'm on a boat and I'm on the outside of a boat where I look kind of at, when I'm looking at the waves kind of moving around, that's when I kind of get motion sick. Any other time I'm usually good. That's because sometimes in a car, right? Well, why does that happen? We're going to talk about that in our vestibular lecture next semester really heavily. But what it is it's sensory mismatch. So what causes you to get sick? Well, you're sitting in a car, right? Bianca's sitting in a car and she's driving down the road, and maybe Joe's driving her all over the place. And they're driving all over the place, and Joe suddenly gets crazy while he's driving and goes to like get off the 215 and takes the corner at like 90 miles an hour. Well, Bianca's proprioceptive system is saying she's perfectly seated in a car and is not moving, right? Her vestibular system is detecting that rate of change of the curve. And her visual system is saying, well, everything looks kind of nice and even out there. So there's a sensory mismatch going on. And so the body says, I don't know how to respond to this other than puke, right? Especially when you're reading heart. And why does that happen? Well, because again, like think about this. So let me see. Let me grab a book here. Like, there we go. My Pathfinder book will work, right? So I'm sitting in a car and I'm reading. And I've got focus down here. All the words are stable, right? My proprioceptive system says I'm stable, but my vestibular system detects that we're moving in a car. And all of a sudden I look up. And when I look up, I see that things are going by. So now I've got a visual mismatch. I'm going to talk about that in a second, Amanda. It's a really good question. And actually, Stephanie, too. So now, Daniela looks up and all of a sudden the stuff's moving by. And all of a sudden she's like, okay, I don't feel so good. Because the vestibular system all of a sudden goes into overdrive and says, oh my God, I'm moving too much. And kicks up the sensory system on that. And so Stephanie asked, well, how does Dramamine alleviate that? A couple of different ways. So Dramamine is a CNS suppressant, so central nervous system suppressant. Really what Dramamine does, and so does stuff like inactively, like Benadryl and stuff like that, it just tamps down your nervous system response. So it doesn't necessarily mean that it stops it, but what it does is it just kind of lowers your overall threshold to get that vomit response going, right? Where you kind of get sick from it. So it takes a little bit more sensory input. So again, if we go back to that, Bianca and Joe in a car idea, if Joe all of a sudden does a figure 8 and starts spinning around and doing like Gymkhana type stuff in his car, she may still take Dramamine and be good, but then eventually, Dramamine will put you out too a little bit if you're not careful. Eventually, she's going to hit a point where the Dramamine can't counteract the amount of sensory input she's getting. She's still going to have a vomit comment. And then Amanda asks, why does it affect more people than others? And if you actually get into that, you can see that it not only affects more people than others, some people more than others, but it can also affect differently depending upon the day. Like for myself, I found if I'm hydrated more, Amanda, I'm not as susceptible to getting motion sick on a boat as I am if I'm not hydrated. And that goes into the way the inner ear canals are worked and the fluid in the inner ears and stuff like that. That ties into that. That makes sense to me. The other thing is, so I can talk about that. Amanda asked a good question. I'll talk about that in a second. The other thing is, some people so we're going to talk about this next semester. So I'm going a little above where we are. We all have a tonic firing rate in our ears. And what a tonic firing rate means is each of our ears are firing at a certain amount of pulses per second. And when I talk about ears, I'm talking about the actual vestibular apparatus in our ears. They have a certain frequency they operate at. Usually it's between 80 and 100 pulses per second or hertz. Some of us have a higher hertz than others, meaning that those inner ears are a little bit more sensitive to change. Those are the people that end up having a little bit more sensitivity to motion sickness than those of us that may be a little bit less, right? And it can happen on both spectrums. So as you get older and your hertz in your inner ear is kind of lowered down, you're more susceptible to it because it'll increase that change of voltage in your ears a lot greater than it would be if you were like firing at 80 hertz and suddenly you go around a corner and it bumps it up to 100 hertz versus going 60 to 100. So it's a kind of advanced topic, but it really has to do with the way your inner ears fire. And so those pressure point bracelets, honestly, if you really want my answer to that, all that is gate control. So pressure point or magnetic bracelets, I love those. Right? It's literally just there's part of placebo that goes along with it, Amanda, but the other part is gate control, right? Because I think about, I've got that bracelet on my wrist. I'm not thinking about as much as my inner ear making me vomit. It's a distraction. Yeah. And Christina said on my road trip, dog has to have small doses. Yep. I had the same thing when I brought my cat across country. She had to get a little bit of Dramamine, and she had to get a little bit of Benadryl because she was spastic in the truck. Prednisone, yeah. And again, if you look at those, so when we talked about Dramamine and we talk about Benadryl, they're all kind of antihistamine type drugs, and they trigger on the central nervous system. As well, trazodone, same idea. In reality, you could even probably give somebody something like a Xanax, which is another kind of central nervous suppressant, and it would probably work just about the same. The interesting thing that I found that's kind of interesting in humans is ginger seems to have the same effect as Dramamine, which to me is really interesting. And I've never actually, I've studied a little bit of the effects where ginger kind of is central nervous kind of suppressant. But like drinking a ginger ale works a little bit, or if you take something like just a ginger root capsule, sometimes that'll work as effective. Yeah, it's one for pregnancy, right? It'll work as effective as taking a Dramamine pill, and maybe you don't get the side effects of being sleepy that the Dramamine pill gives you. So for those of you that might get kind of motion sick, try ginger once, see if it helps you. And you're like, I hate ginger. Well, I can't help you there. But it's interesting. I have a friend that swears by that. And so when he travels, he has these like dried ginger roots he chews on when he's traveling. And it keeps him from getting motion sick. He gets motion sick on planes, which is really odd. There's not a lot of people that get motion sick on planes, but he gets really motion sick on planes, especially if he's sitting in the window where he can see out. So he tends to sit in the middle seat, and he has these dried ginger roots he chews on the whole time. And part of it, I'm sure, probably like Amanda asked, part of it's probably, so because her dad gets the same way, right? Part of it's probably psychosomatic effect, meaning he's chewing on it, so he's not thinking about his motion sickness. But part of it also is that it might work. So we have our somatosensory system, which kind of gives us our proprioceptive input, so our feelings, right? All of our mechanoreceptors in our body. We have our inner ears, which are a vestibular system, right? That provides us with motion of rotation, up, down, side, side, forward, and back. And then everything gets organized kind of in what part of our brain handles primarily our balance? Does anyone know?
Cerebellum.
Good. Cerebellum. Good, right? And the cerebellum is going to take input and deliver input to the cerebrum, right? Which is then going to implement the plan, the motor plan, in order for us to be able to compensate, right? Cerebellum's going to send stuff down that spinal-vestibular, vestibulospinal tract in our back to keep our balance in line. You can have a couple different kinds of balance control. If you guys remember a little bit about this from anatomy? Yeah, I'll talk about that in a second, Joe. That's actually a really interesting theory. So hold on to that just till we get through the slide, and I'll talk about that. So we have a feed forward, or that open loop system that Dr. Johnson talked to you guys about, right? So the open loop system is where things occur too fast for a feedback system to kick in. We have to do anticipatory control, right? Where we start moving around to control our balance, right? So if I come and I shove Joe really quick, he's going to react on a feed forward response, because it's not like I'm giving him little perturbations, which he can kind of control with his sensory input. If I just come up and just give him a good old fashioned shove into the lake, he's got to actively activate his cerebrum to start thinking, to feed his cerebellum to say, how do I save myself from falling? And the answer may be, I can't, I can only fall, right? Maybe it might be too fast for it. Anticipatory control, we all do, right? Think about going down a stairs. Like protective response from growth and development, John, look at you. So let me say, you're in what phase of motor learning there? Associative, there we go, good, right? Because you just associated something. Doesn't mean that you're not still in cognitive learning this, but you just associated it with something else you learned in another class. Good. So anticipatory control, you're going downstairs and you look down the stairs, you see how low the next step is. Does your body automatically kind of react to that and know where the foot needs to go, know what needs to go, and your balance stays in, right? But has anyone ever done that where they put their foot down, they're not paying attention, and they miss a step? Right? That would be that feed forward idea where, oh my God, I can't anticipate ankle sprains, right? I can't anticipate that, and I've got to figure out a different way. And sometimes that leads you to falling, right? Because maybe your cerebrum doesn't kick in fast enough and tumble down you go, right? Or you get a motor plan going, oh, well, if I quick step out here, I can keep myself from falling. All of that kind of comes into play. And then a closed loop control. So Anthony says he plays basketball, right? So let's say, we're playing full court basketball and Anthony's out on the wing and I'm kind of into the basket and I block a shot from another player, get the ball, and I quick pass it out to Anthony. And Anthony's on the run already. He has a certain amount of closed loop control and precision movements that he can think that ball's coming in. Amanda steals the ball, right? That ball's coming in. He's got to adjust his posture a little bit to catch that ball and start immediately dribbling. That's kind of that closed loop idea where he has those precision movements that he has to get the feedback, right? He has to feel the ball hit his hands. And then once he feels that ball hit his hands, he adjusts his posture a little bit to allow a little bit of that recoil from the ball. And then immediately transfers that ball maybe to his dominant side and starts dribbling. When you think about all of that happening in a matter of a second, it's pretty impressive that we can do these type of things, to me, right? Like one of the big people that still amazes me this day is Odell Beckham Jr. Like if you see some of the catches he makes with his balance, right? One-handed, fingertip catch, pull it into the palm of his hand, pull it down, and land on one foot on the sidelines, and then get the other foot and tap that other foot before he goes out of bounds. That takes a lot of precision and training to build those closed loop controls that he can do that. So when we have balance, and I want to switch cameras real quick on this one. When we have balance issues. So when I have a balance challenge, if I'm standing here, right? The very first thing that happens is kind of ankle strategy. So that happens in the anterior posterior plane, right? So if I start losing my balance, I start causing some sway to occur out there at my ankles. The other thing that can occur is if I start losing my balance, maybe I'm going to the forward and left, I can now weight shift and adjust my weight in the lateral plane to bring it more in line with my center of balance. The next kind of step we have is suspension, or what's called the knee strategy. I'll answer your question in a second, John. Let me get through this real quick. So we have an ankle strategy, right? We have kind of weight shift, which is more almost like an inversion, eversion strategy at the ankle. Then we have suspension, which is our knee strategy. So maybe I step down, I start losing my balance. The next thing I do is drop. So I give a little bit of knee flexion to lower my base of support, right? Suspension, I start tightening my hips in either an anterior or posterior pelvic tilt to bring myself back over balance, right? The hip strategy. The last thing I do before I fall is I'll step. So that if all else fails, I'm going to take a big step to really widen my base of support. And in reality, when I have a challenge on my base of support, I kind of do a little bit of everything to kind of keep my base of support and keep myself from falling. So when your boards, or when I have a question on your test about strategies to keep your balance, it starts at the ankles, right? So you have AP, ankle control, lateral medial or right left ankle control. Then you have the knees or suspension strategy. Then you work at the hip and the low back, and then you have the step. Or you can just combine all of them if it's a massive, like if I come up and I shoulder charge John really quick and just ram my shoulder into him, it's not likely his ankle is going to be able to save him. He's going to probably have to have a combination of all of those motions to keep from falling. And so John asked, do you work on reaction times to improve balance control? Well, yeah, I don't know. John may be able to take me if I shoulder charge him. I'm just saying. We'll see. I think I've got him by about good, probably 70 pounds. So I think I might take him out. I've got most of you by a good bit of weight. So John asked, do you work on reaction time? Absolutely, right? So like thinking about the way we work on balance, and we're going to talk about it, right? We work firstly, that's a word. Firstly, in kind of a static plane, right? Just working in a standing, not moving. Then we work with movement and reacting, right? And then we work on an unstable surface. And then we just keep kind of progressing. And so sure, reaction times can really help balance control for sure. Right? You don't see a wide receiver instantly working on going up, jumping, catching a ball one-handed. No, they work on the kind of the base stuff on reaction times first. And the faster reaction time, right, the more you'll actually react better to balance. So what kind of conditions can we have? Well, during stance, meaning standing up or even sitting. I'll add that to kind of here as well, because I talk about standing a lot. But we can also say sitting, right? This is going to be a static balance activity because we're not moving, right? But we can also talk about being a static or a dynamic surface. What is the difference between a static or a dynamic surface?
Dynamic, it means the surface is moving, so you could put them on one of those like half balls.
Good. Yep. So like the Bosu ball, or even an Airex pad, or honestly a pillow would be a dynamic surface, right? It's something that's going to challenge my posture. That's okay. That's why I kind of go over it. I bet there's probably one that you guys have never thought of, but has challenged your balance in the past. Has anyone almost fallen getting off those rolling floors at like the airport? The moving, like Chris, like every time, right? Well, why is that? Well, it's because again, what I find is especially if you stand still, you have a tendency to fall when you get off it because your body's like, I'm standing still, but I'm moving. And now I stop moving. Face plant, especially after a couple cocktails. I don't know anything about that. But again, why would that actually ties into another thing? Why do you think after a couple cocktails or maybe after a couple beers or a couple shots, your balance is impaired? There's a couple reasons. Number one, your cerebrum's impaired, right? Cerebellum's impaired. And your vestibular system's a little dried out because alcohol is, it kind of dries out stuff. It dehydrates you. So all of that ties into the fact that, that's when you get up from the bar stool and you're like, I'll be right. Oh, you know what? I'm just going to stay here for a while, right? Because your balance is way off. Tie that into the moving floor now, and whew, what I really enjoy when I go downtown is watching one of my most favorite things is watching people that have had a little too many get in one of those spinning doors. Because I actually watched one guy get in that once and just go around it 4 times, and he couldn't figure out how to get out of it. It was fantastic. And it was not one of the ones that like constantly rotates, like, how some, I think the Bellagio has them, they constantly rotate. This is one of the ones that he pushes. So he just kept pushing and going around and around and around. I don't think he knew how to get out of it. It was great. It's like a hamster wheel. Exactly, Joe. Get out of my head, you guys. So we can do static, meaning not moving and sitting or standing on a dynamic surface, or we can do static sitting on a static surface, right? Even this chair that I'm on right now technically would be a dynamic chair surface, even though the seat portion of it's pretty static. It rolls, it turns, it goes up and down, it tilts. So that could technically be a dynamic surface as well. And then we can get into balance with perturbed, standing or sitting again. So perturbed is where I'm going to come up to you and push you around a little bit. We can work on balance with whole body lifting, meaning doing lifting activities. And we know we should always lift with our legs, not with our backs, right? We learned that from Dr. Sokel, I hope. And there are all kinds of stuff we can do with whole body lifting, right? If I just go down and I kind of squat down, pick something up and bring it up, it requires a different balance than if I do a golfer's lift, where I kind of do that one-legged lift and kind of rotate up and down. So the whole time during that, my center of mass is shifting all over the place. So I have to anticipate where I'm going to be mentally thinking of, and again, when I say mentally thinking about it, you may not be actively thinking about it, but your brain is. And kind of anticipate what's going which way in order to keep the self from losing balance. When we work with patients, especially ones that have to lift a lot, we can't ignore balance because a lot of patients may be able to lift really well, but as soon as they start picking something heavy up, they lose their balance. Pregnant mommies, particularly, right? When they get baby getting really big and kind of that baby shifts their weight, where all of a sudden the baby's now kind of on the more anterior surface of their body, throws off their balance. So we have to teach them how to stand up and sit down with a change of their center of mass. Anticipated weight and momentum is when we start doing stuff like moving and adding weight to them, right? Again, even something as simple as like a football can affect that because a football may be a small object or a basketball, but it changes your weight. It changes where your center of mass is. And so our body's got to think about that. And if we get something where we're having balls thrown at us where we're adjusting, we may have to step in order to adjust for those changes in weight. We talked about kind of the methods of correction for loss of balance, but if we don't have an active method of correction for loss of balance, well, then we fall, right? And then we have to teach patients also how to fall. One of the big things we'll talk about in spinal cord injuries and also like strokes and stuff like that, when we're talking about moving a patient around in a wheelchair, and I hope that Dr. Sokel talks about this, is not only do we have to teach a patient how to move around in a wheelchair, but we also have to teach them what happens if they fall. Because it's not an if they'll fall out of the wheelchair, it's a when they fall out of the wheelchair. It will happen. It'll tip backwards, they'll fall out anteriorly from the wheelchair. Something's going to happen where we have to teach them how to fall properly. Center of mass shift, Joe. So center of mass. So let me get here. I'll give you a demonstration really quick, just so you kind of sticks a little bit for you. So what do I have? I'll use this book, right? So if I've got this book on the floor, right? I just toss my book on the floor. When I go down to pick it up, my center of mass stays between my legs, right? But when I pick that book up, and I've got this now in my hands, my center of mass has shifted a little bit this way. So how can I compensate for that? Well, if I lift all the way up, I kind of got to put my butt out to bring it up. Or I can take the book and bring it in so my center of mass is back where it was and lift with it. So it's all about adjusting that center of mass when you're doing stuff. My professional studio here. I just muted my video. That was great. That's what I wanted to do. There we go. So what can impair balance? Well, sensory impairments are one of the big ones. But also tied into that is perceptual impairments, meaning that we may have active sensory, but we can't interpret what our sensory input's giving us. So vision's a big one, right? Is a blind person going to have problems with balance?
Yes.
For whatever reason, my headset just turned off. That was great. So yeah, blind person is definitely going to have issues with balance. And that brings me back to, I forget who it was that, oops, I didn't want to do that. Who was it that asked about the tongue? Who was that back here?
I did.
Yeah, Joe. So why this is kind of interesting, and it's, so there's a condition called Wobbler's disease. And actually down here, I talk about gentamicin down here in medications. So gentamicin is an antibiotic. It's a really broad spectrum, strong antibiotic. It's also known as an autotoxic medication, meaning it destroys the inner ear. But for somebody that's got a really bad infection, like something like pertussis, or even what was it we were just talking about, tuberculosis, gentamicin may be the only option for them, especially if they can't have penicillin. So can the tongue play into balance? Absolutely. There's an interesting study in the one book that I read, which is called The Brain That Changed Itself. And again, I'm going to highly recommend. If you can pick that book up and read it, it may change your idea on neuroplasticity. That's what the whole book's about, is neuroplasticity. But in that, they talk about people that have Wobbler syndrome, where their inner ear has been destroyed by gentamicin. And they train their tongue to be used for balance. So what they do is they put these electrodes on the people's tongue that when they lean right or left, the tongue gets the input from the electrode that they're leaning one way or the other. And when that happens, they adjust their balance because of it. So what they found interestingly about this in this study, that's a long-term study this guy did, was they thought, well, okay, if we leave those electrodes on, because what they're thinking is we'll develop a device that the person can put on their tongue so when they're moving around, they can have balance. But this neuroscientist found out they took the electrodes off the tongue and the patient still had balance. And they actually maintained balance for a short period after those electrodes being taken off the tongue. As the tongue adjusted and adjusted in their mouth, they actually found muscles firing in the tongue as the person leaned left, right, forward, back. And so the tongue became the proprioceptive point for balance, which to me is amazing, right? And they found the more they trained the people on these electrodes, the longer that balance stayed, to the point that they actually have a lady who only comes back about once a year now to get training, and then she's able to have good balance for the rest of the year. Right, Riley? Like, it blew my mind when I read about this. So yeah, I mean, we can, and that ties back to those latent pathways of neuroplasticity, right, Joe, that exist in our brain. So yeah, sure, you can use your tongue eventually for balance. And I mean, I don't know. I mean, I see enough athletes that sometimes have their tongues out when they're doing stuff like that. So maybe that's their way of helping balance too, or maybe they're just tasting the air. I don't know. Yeah, exactly, right? Yeah. That's why MJ can fly, exactly. So poor vision can lead to it, low vision can lead to it, but also light levels, right? We've all done this in the morning, or like at the middle of the night, you get the urge to get up and go to the bathroom, and you get up out of bed, and because there's no lights or whatever, man, you're just all over the place. because you're not getting that visual input. Or it's too bright, and that can affect your balance. Hearing also plays into balance because hearing is close to our vestibular system. And then so does smell. Believe it or not, they're finding out that sometimes if you start losing your sense of smell, not only can it be a sign of early onset dementia and Parkinson's, but it can also be a sign that you're having vestibular issues. So there's a lot of studies that are starting to link smell to a couple of other senses, which is kind of cool. Again, sensory motor integration and coordination where we can't interpret or input the either proprioceptive, vestibular, or visual input that we get. Biomechanical and motor output deficits. So here we have this term apraxia and ataxia. This is, we're going to cover this from a base level. So ataxia. Have you guys heard of these terms before at all? Maybe in bio or anything like that? Dr. Johnson talk about these?
Yeah, I always get them confused though.
That's why we're going to talk about it. So here is my secret to remembering this. Apraxia has a P in it, so it's a problem with the motor plan. So motor plan. So what that means is if you have an apraxic balance problem, all of your muscles and nervous system, for the most part, from the brain down, are intact. But the plan that you've developed in your head in order to control yourself is no longer intact, right? So this is common with apraxic gait. The patient has perfectly normal muscle tone, perfectly normal nervous system going to those muscles, but you ask them to walk and they just can't remember how to walk. They've lost that plan, right? So a lot of times this apraxia is a combination of cerebrum and cerebellar involvement. But again, when we talk about motor plan, primarily that's up here in the cerebrum, right? Or cerebellar area. Or cerebral processing area is what I want to say. It is a neuromuscular issue, correct. But primarily, again, a lot of times with this, it's more of a pure CNS issue because the plan is no longer there. So think about this, like right now, if I told John to go out and play water polo, he may have seen it on television, but he doesn't have a motor plan developed to play water polo, right? So technically, while he's trying to get this, he's a little bit apraxic in doing it because his motor plan is not developed. He practices over time and over time and over time, and he's going to get better at the planning of playing water polo. So he'll develop an internal plan or a muscle memory, if you will, right, on how to do activities. Versus ataxia, and I think it's very taxing to do things. And what that means is we have our plan, plan's intact. We know how to do things. So like in the case of balance or in the case of walking, we know how to do it, but for whatever reason, there's a neuromuscular disconnect. So that could be that maybe the descending tracts, the motor tracts coming down from the brain are damaged. It could be that, you've got a neuromuscular junction at the muscle that's damaged. Could be the whole thing, right? So this case, you know what you're doing. So this would be one where you're like, I like to think about this, where you tell a patient, okay, I want you to stand up. And they're like, I know what I'm doing, but I just can't do it. It's not working. I'm telling my body to do it, but it's not happening. Does that make sense for what ataxia kind of looks like? Versus apraxia, you tell them to stand up and they're like, I don't know how to do that. That's kind of the idea of apraxia. They won't say that, but you'll tell them to stand up and they'll lay down or something like that. They don't have the right plan in place to actually implement the motion you want. So in the case of balance, if I'm ataxic in balance, it means that I may be thinking, okay, I've got to step in order to keep from falling, right? So the plan's there. I know I've got to do that, but I send the signal and nothing happens. And so they end up falling because the plan can't be implemented. Versus apraxia, you know, I give a little perturbation and John has absolutely no idea how to actually implement his step strategy because it's not there. So he's just going to fall because he has no plan to prevent it. I know it's a complex issue, but it's a key to understanding a little bit of neuro, but does that make sense in general? We're going to talk about different types of apraxias and ataxias later.
So, Mr. McKeever.
Yep.
For example, so would you say ataxia is forgetting how to walk and apraxia is don't know how to walk?
So I would say apraxia is don't know how to walk. That's a good thing there. Ataxia is more, I know how to walk, but for some reason I can't. Yeah, it's a neuronal misfire. It's a neuron's not being there. I mean, there's a ton of reasons it could happen. Like, let's say I have a spinal cord injury. So maybe I have a T10 or T5 spinal cord injury. So right about here, right? I would be ataxic in my legs because I would want to walk, but there's no nerves going to those legs, right? And so even if I maybe had partial function of my legs, when I'm walking, right, what am I going to look like? I'm going to be like all over the place and not firing properly. So yes, a neuronal misfire. Or it could just be those neurons aren't there, right? They're cut off. You tell me to stand up and I'm like, dude, I'm a spinal cord injury. So patients are so good. So Anthony says, so stroke patient with slap foot would be potentially ataxic gait. Exactly, right? Unless they say, you tell them to dorsiflex and they're like, oh, what are you talking about? They never learned to walk that way or whatever. That plan's not in place. Then that's why we're going to work a little bit of the plan and also some of that neuromuscular control as well. Complex topic, but we're trying to hit it like 1,000-foot level right now. So that next semester we can get down into the weeds and talk about like idea motor versus ideational and stuff like that. Does that make sense? How is my favorite Brooke doing there? Does that make some sense, Brooke?
Yes, that makes
Okay.
sense.
All right. So that's that apraxia versus ataxia. As we get older, our balance goes to crap. There's just no way of putting it, right? Our muscles get weaker, our bones get weaker, our vestibular system ages, we lose our balance. The number one reason people over 65 go to the doctor is because they fall or they're afraid of falling. We talked about medication already. What other medications can affect balance other than gentamicin, which I mentioned is autotoxic?
Anything that just like makes you drowsy or out of it.
Yeah, so all of our opiates, right? Benadryl can affect your balance. So anything like that can affect your balance. Anti-CNS suppressants, right? We have muscle relaxers versus antispastic drugs. Even some antidepressants, right, can affect your balance long-term. So all that happens. Behavior, right? If they don't get up and move, right, and they lose that, or even in the range of motion here, right, that's going to affect their balance. Musculoskeletal issues, right, biomechanical alignment, weakness, poor synergistic organization strategy, anything where they've got one muscle tight versus one muscle too loose, that can affect balance. And then the inability to adapt, right, meaning that you're not able to adapt to changing circumstances can affect your balance. I only have a few more slides. I'd like to just kind of pound through this and hopefully get out a little bit early. I'm not going to read through all these balance tests, but all of these are kind of balance testing we can do. The most common balance test you are going to see is this one right here, the Berg. The Berg depends upon how safe a patient is. If you look at this, it's 87% specific for predicting falls and 87% specific for predicting multiple falls. So a perfect score is a 56. The lower your score, the worse you are, right? So if you're lower than 46 on the Berg scale, it's a prediction that you might fall in the future. I think if you're lower than 30, don't quote me on this, it's definitely a prediction. There's the Kinetic, there's timed up and go, four stair. We'll practice a few of these in lab, specifically the four square step test, which is where you're reaching in 4 different directions. But the Berg is the big one you're going to see. Up here, progressing and coordination tests we can do that help with it. But all of these tests will determine how much a patient is likely to fall. That is kind of the idea behind testing for balance, because the main goal is if we could demonstrate a patient is likely to fall, we can validate physical therapy. Like, think about some of your meemaws and papaws, grandparents, or even your parents maybe, because some of you may be older and parents are older as well. You could probably test them and find out they're at risk of falling, and they would benefit from physical therapy to help prevent them from falling. Because here's the deal. It is cheaper for insurance companies to pay for preventive physical therapy for falls than it is to pay for hip surgery. I wish we would think about this more frequently, and maybe once you get over 55, you have to go in once a year for screening for falls. I think that would prevent a lot of our hip fractures. But, you know, I don't know why we don't do more preventative training. In October, like I said, is for the APTA is what's called Falls Month. Get it? Because it's in fall. And a lot of the clinics will get together. Last year, we didn't have it, but the year before, we had it down at the Smith Center, where a bunch of clinics got together and sent a couple PTs and PTAs in. And old folk came in, and we ran them through a couple stuff like the timed up and go. I think we did the Kinetic. And if they were younger, we might have done the four square test. And we ran them through a battery of tests and screened them for falls. And one of the biggest questions you ask them is, have you fallen in the last year? Because if you've fallen in the last year, you're likely to fall in this year. And then we would say, recommend, hey, you know, you got a high score here, or a low score, but a high probability of falling. You really could benefit from physical therapy. And then we had other people that were there that helped them get scheduled maybe for a physical therapy visit, so they could get in, get screened, and get some preventative measures to keep them from falling. I think that's a pretty noble thing to do for us, but we need to do it more often. As we build balance, just like I mentioned before, we've got to build static balance control first. So build stability, and then work on dynamic balance, mobility, and then work on anticipatory balance, reactive balance control, more organization of our senses so we can take that input and react to it faster. Balance during functional activities. Can we have balance in the shower with our eyes closed? I mean, I've done that before where, you know, maybe I got soap in my eyes or I'm washing my face, and for whatever reason, for that quick second, I lose my balance. Like, what the heck's wrong with me? Well, I'm getting old. That's what's wrong with me. Safety during gait and locomotion. Again, any balance activities we're going to do with these patients, they need to have a gait belt on. They need to have a gait belt on. We can work lower extremity activities, right, to progress to balance training. So we start with some seated activities like marching, right? Then work to marching with reaching, and then progress to standing, and then progress to standing while reaching and lifting. We can move them to sitting on a physio ball, which are those big medicine balls, or a Swiss ball, right? And then work on going up and down. So vertical weight bearing, going up and down stairs, or progressive balance training where we actually add some different techniques to really challenge it. You do closed kinetic chain activities like double leg squats, forward and back gait, sidestepping. Heel toe walking is one that people really hate doing. But it's a really good key if you've got balance issues, right? And when you walk heel to toe, the big thing with heel to toe walking is, can you walk heel to toe, rapidly change directions, and then keep walking heel to toe? That really challenges your balance. And then braiding, that's where you cross over the legs, or otherwise I've heard it referred to as karaoke. We can work on more advanced balance control, hopping, right? With kids, we start hopping on 2 legs and then move to 1 leg, and then work on hopping from 1 foot to the other. So same thing we can do with adults. We can move to mini tramps, balancing on a mini tramp, right? Especially if we've had hip, knee, or ankle surgeries or injuries, we can work them on a mini tramp, where that mini tramp is a very dynamic surface to stand on, It helps build stability. Single leg, double leg standing, hopping with eyes closed, all that can happen. When you close the eyes, you knock out one of your senses. You can also knock out hearing. Put a headphone on them. That can knock out some hearing, some balance. The BAPS board, I don't know if any of you have ever seen the BAPS board, but the BAPS board is usually, it's blue typically. And the BAPS board is this rounded board where it's got a right and a left foot on them. So it's right, that's a really bad foot, but you get the point. And then you have this half ball that you can put in different places on the BAPS board, right? You use that a lot on ankle patients. Exactly, Anthony, right? Usually there's one right in the middle you can do. And so one of the mistakes that a lot of people make when they're having patients do this is they'll say, okay, work on dorsiflexion, plantar flexion, inversion, eversion on the BAPS board, and you hear the patients doing this. And you hear that BAPS board smacking the floor. Right, they do it way too fast. The goal of the BAPS board is to be quiet, so they should be controlled so that they go forward and you don't hear that smack of the BAPS board. Right? And honestly, you can even work it where they don't touch at all. They've got to control it. They don't listen. Right, Joe? They never do. Right? Wobble boards are another one. That's usually where they have kind of a piece in the middle of it and wobbles back and forth. But here's the deal. Patients can create their own wobble boards at home to work at home. How can they do that? Well, it's really simple. Right? Watch, I'll create a wobble board on my own. I've got a book. I've got a bottle. I've got a wobble board. Right? So it doesn't take much to create one even at home for them to work on stuff. So, you know, I love patients that say, well, I don't have this stuff at home. You have the stuff to do most of the activities you do in physical therapy at home. You just don't think through it enough. And then you start involving the upper extremities, right? When we start balance, we primarily work the lower extremities. Then we start working the upper extremities in. So progress by doing stuff like catching, moving the shoulder, right? Lifting heavy balls outside of your base of support. All that stuff can start improving balance. For the elderly patient, the good thing is this Otego home exercise program. I have it on the next page. It's a home exercise program that reduces falls in older adults, consists of 17 strength and balance exercises that they should do 3 times per week. It's only about 30 minutes, but they should also walk for about 30 minutes twice a week. They can do group programs where we bring Parkinson's patients in as a group and work with them. We can do circuit activities. Or this is really interesting is Tai Chi really works on patients' balance. Or as one of my kids used to call it, it's like slow karate, which I can't argue with them. It really kind of is, right? It is. So Tai Chi is really good for balance. And there are actually a bunch of Tai Chi offerings in town for older adults. And believe it or not, it can be beneficial for even you guys. You'd be amazed at how much a little bit of Tai Chi can really challenge your balance. I don't know if anyone has ever done Tai Chi, but it challenges me. And I've studied the martial arts for years just because of the slowness of the movements. So here's kind of the Otego program. So you do 5 reps of all things, stand up tall, look ahead, turn slowly to the right, turn left as far as possible. And you can read through these all. It gives a warm-up exercises, then a bunch of exercises for patients to do. Honestly, this is not a bad program for even if you have grandparents or parents that they could do 3 times a week that would improve their overall function. I mean, all these are pretty decent exercises. Knee bends, walking backwards, walking and turning around, sideways walking, stuff like that. It's very low impact activities, but it's shown dramatic backwards walking is underrated, 100%. Yep. It's really good for balance because it knocks out your vision. But all of this can be really useful just for improving not only balance, but overall functional activity. If we have a post-trauma or post-op, first thing we have to address is loss of strength, address their pain and swelling, improve their flexibility, improve their local muscular endurance, and then build up to gait and balance with endurance and cardiovascular fitness and stuff like that. With ankle sprains, do you think a lateral ankle sprain or a medial ankle sprain is going to affect balance more?
Lateral.
Okay, why? What did I say about the fibula? What's its main job?
Balance.
Yeah, balance, right? So that lateral ankle sprain can, and again, the other thing is we don't often sprain that medial aspect too much. And when we do sprain it, it tends to be worse. And so patients stay off their feet, and so it's not a balance issue anyway. The ACL, why would the ACL affect balance? What's the ACL's job again?
Controls anterior movement,
Yep.
I think.
Yep, good. It controls anterior shear, right? So controls that tibia moving too far forward on the fibula, right? And so think about it, even if I'm doing like knee flexion activities or walking, if that kind of shifts out of place, now my ankle's got to control that weird movement. And that's going to cause all kinds of balance issues. And then low back pain or radicular pain, where pain is radiating, is really common for affecting balance, because once we affect this, right, our core, or even a core injury, maybe pregnancy where you've had a separation of that linea alba, right, diastasis recti, which is what it's called for when that happens, when you get that split. Or I've actually seen it where a patient's had a hernia, specifically an umbilical hernia, that something as simple as that has affected their balance. Well, it's because their core muscles now aren't firing at the right rate. And so because the core is out of control, you have to use your legs to control it, and that's going to affect your balance. Leaning to one side, exactly. Right? Especially if I've got like low back pain on my right side, I'm kind of like walking like this, right? I'm like, oh, that hurts. Or worse, if I've got bilateral back pain and I'm kind of leaning like this, right? Because we always tend to kind of flex towards either towards or away from the pain, depending upon if we're a flexion or an extension responder. So last, an older mom, I have an older mom constantly holding on to her. She's still wobbly. Yeah, it's sad, right? Give her the Otego exercise program. Seriously, Anna. I mean, it doesn't hurt. It's a lot of easy exercises. She may actually find that she gets better at balance with it. I mean, it can't hurt. Right? Again, we're not diagnosing, right? We're not diagnosing. We're not saying what's causing her problem, but we know that that program helps patients improve their balance. I mean, it's really, yeah, right? And again, prediction, if she's fallen a lot, she's going to fall again. And that's kind of something I talk to my older patients about, is if you are one person that has fallen a lot, you are likely to fall again. And you are likely to fall worse typically. I want to adjust my camera over here because we're going to just do some talk through basic exercises in a second. Same with my dad. Right. So let me switch cameras here real briefly, and we're going to talk briefly about progression of balance, and then I'm going to let you guys go for the day. All right. So we're going to talk briefly about progression of balance. I'm going to bring this up just a little bit more. So I said the first thing we're going to work on is static balance. So that literally means I'm sitting on and we're going to pretend this is a static chair because I don't have a static chair here. I'm sitting on a static surface, static balance, and I may just be sitting here unperturbed, working on keeping my body upright. What could you put in front of me that would help me see if my body's upright and not leaning? I'm here, good, right? Or I can use exactly what I've got here. I'm using the screen, right? Upright, nice and balanced. When I start with a patient, I'm going to start with them with bilateral handheld support. So this is the most basic balance training I can have. So I've got my hands down on my bed or my mat, and you're going to say, okay, sit up nice and tall, Mr. McKeever, and we're going to hold this position for 30, 45 seconds. All right, good. Now I'm going to get my hand, I'm going to let them rest a little bit. Okay, let's do that again. What do you think the next progression is? So I'm bilateral hand support, you have me up late. What's the next progression?
Take a hand away.
Good, so, right, we'll start with taking one away, right? And then we can progress to taking two away. Right, so now I've taken my two away, now I'm sitting here, okay, ooh, that's a little harder. All right, I get my balance, we'll sit here for another 45 seconds or whatever, good. What could be my next progression? What can I do to my feet that would challenge balance?
Cross them.
Together.
First of all, good. First of all, start together, and then exactly like somebody said, I can cross them even, right? So I can start with bringing them closer together. That's narrowing my base of support. Now I don't have this, oh boy. And maybe at that point you may have to say, okay, put one of your hands down. Okay, get your balance. Now pull that hand off. All right, let's work on balance. Okay. So I've worked on that. I've gotten pretty good at that. What could I do with where I'm sitting on the mat that would challenge my balance?
Close your eyes.
Well, we're coming there. Almost. Let's just talk about placement on the mat. So I'm sitting on a mat at the clinic.
Scoot forward.
Good. Yeah, right. So now I scoot forward. Now I have less of my leg in contact with the mat. I've drastically reduced my butt bones on the mat. Now okay. Whoa, that's really rough. Okay, put your hands down. Okay, get your balance. Let's pull one up. Let's pull two up. Good. Let's narrow your base of support. All right, let's sit here. Good, right? All right, do you feel yourself swaying? Yep. All right, keep yourself upright. There you go. Good, Mr. McKeever. Good dog, good dog. So now I've got that. Now I can start going to some more advanced stuff. So usually for me, the next thing I go to is eyes closed. So now I'm going to move them back probably because I want to give them a little bit better base of support. I'll say, okay, let's bring your hands up and let's close your eyes. Okay, good. Hold your balance there. I could even just close one eye if I wanted. If I've got a dominant eye, I can close my right eye. Close my left eye. Close both eyes. Starting to challenge. I'm knocking out a sense. I could put cans over their head so earphones that block out sound. That could add stuff to it, right? We've done everything kind of in a static. What could I do about the surface?
Dynamic, change it to a dynamic surface.
Yeah, exactly. So we'll pretend that my little binder here is a Dynadisc or something. I can put that under my bottom. I've now changed my surface. Oh, that's got a pencil in it. That's not very comfortable. Let's just not do that. So and I change them onto something that adjusts my balance here. And then I can go back to the same thing. Start out here, lift one, lift two, right? Bring my base support together, slide out a little bit more, reduce my overall function, close my eyes, adjust my hearing, right? Now, when I'm doing all this, would I want them in an open environment or a closed environment at first?
Closed.
Yeah, right? Start in something like I'm in now, where everything's nice and quiet except for my blasted loud air conditioner. I start in that nice closed environment. Good, right? So I'm doing that. Okay, good. You got that, Mr. McKeever. You're doing really well. All right, so now I've changed the surface. Did pretty good. I've done static. I've done pretty good. Now, is there any type of movement I could do in seated that could challenge my balance? What could I do that could challenge? Okay, rocking, right? I can start lateral rocking. Good. Do anterior posterior rocking.
Could you
Good.
lift up your feet?
Yep. Okay. Good. I can move my feet. I could just start with just doing ankle pumps, right? Let me slide back here some. I can just start doing ankle pumps, right? Boom, boom. That's going to challenge my balance. I can start marching. Good. What about my arms? What can I do with my arms?
Cross your chest.
Okay. Cross my chest. I can then also start with what's called in plane reaching. So in the same plane, meaning reaching out ahead of me, reaching out ahead of me, reaching out ahead of me, maybe moving some books around or moving balls or cones are the big thing we do in the clinic, right? And once we start doing in plane reaching, the next thing we can do is what's called cross plane reaching. So now I'm going to say, okay, grab a cone here, move it over here. Grab that cone I just put there, move it back over here, right? Or maybe I grab that one over here and move it back out. So I'm doing some cross planar reaching. So I start off with something simple like cones or a book. Could I move to a medicine ball? Would that challenge my balance? So maybe a 2 kilogram medicine ball. Right, so those heavy balls. Right now, think about it. Now I reach out here for it. Think about what happens to my center of mass. All of a sudden I'm shifted forward, so I've got to control it and move it, right? When I'm doing all that, I'm combining vestibular work, visual work, along with core activities, right? Because I've got to have an active core in order to do all that. And then I can add a dynamic surface again, right? Add back that dynadisc or add back that Eric's pad underneath me or a pillow. You see how that kind of progresses? Does that make sense to kind of everybody a little bit? I see Jason's kind of nodding, right? And there's not really a limit on what I can do. I can do reaching way out here as well. I could do reaching where I'm reaching down to pick something up off the floor and putting up there. Is that functional activity? Absolutely. Right? This is one where I'm going to start, if I've got somebody that's got balance issues, I'm going to start involving stuff that they do. Like if I've got somebody that's a gardener, I'm going to have them bring all the garden tools in. And I'm going to start moving their garden tools all around them. So when they're sitting here, they, okay, reach for the spade. Okay, got the spade, put the spade back in your bucket. And it's stuff that they would do functionally, right? Or if I got somebody like, I had a little old lady that knits. I'll have her doing her little rolling the balls, and I'll have her put them over there. Okay, pick up your knitting needles, go over here, right? All of that can be used where I'm doing different activities with them. Well, the neat thing is I did all that in seated. Guess what? Now I'm in standing. How do I start standing activities? Feet nice and wide. I may have an assistive device like parallel bars or a walker, right? So I've got double hand support. First thing I do is just like I did in seated. What's the first thing we're going to remove?
Hands.
Yeah, hands, yeah. So we have to get our hands off, either one or two, right? Got our hands off. Okay, good. You got your balance. Good. Let's narrow that base of support down some. All right, we're narrowing that base of support down. Good. Now I've got my feet together. Is that as narrow as my base of support can go?
You could cross.
No.
Got to cross them, good. Or the other thing I can do that really challenges it is, let me tilt it down some.
Do they call it a tandem stance?
Tandem stance, or does anyone know what the other term for this is that you see in physical therapy a lot? This is called Romberg stance. Because the Romberg test ties to it, right? So true Romberg is like this. It's an anterior-posterior stance where I've got a little bit of space. So that's also true tandem. Then you have what's called sharpened tandem or sharpened Romberg, and that's where your feet are kind of like this. So tandem, sharpened tandem. Romberg, sharpened Romberg. Same idea. Right, so I can go tandem, right? Now I can start adding some movement, right? I could rock. Ooh, boy, my balance isn't great, right? I could close my eyes, right? And you'll see with me, as soon as I close my eyes, because I've had so many concussions, if I'm in Romberg, I start losing my balance pretty quick, right? So maybe for me, you might have me hold on to something. Okay, hold on. Put your hands down on some surfaces. Good. Now close your eyes. Good. Right. For a patient like me, I love having a mirror in front of them that they can see how their balance is. We could do something else in standing that we couldn't really do in seated. Right? I can do single leg stance in standing, can't I? Right? I can bring one leg up. Balance. Okay. Now, there's a way I can make single leg stance more challenging, and the cops do that. Hold your foot out there and stare at your foot. Why is that more challenging?
Because it's like throwing off your center, like your center of mass.
Good, it's throwing off my center of mass. The other thing is I've knocked out my visual system. I can't use the horizon for balance anymore. Right? So I can only use kind of my toe, so my vision's knocked out. I also have to have an eccentric control of that leg. Hold it up there, don't I? Right? And I can stand there and you can see my left leg is kind of struggling a little bit with this. So hold it there, hold it there, hold it there, hold it there. So there is this one fun test that we'll do in class that I think is the dumbest test ever. It's called the Stork test. So the Stork test is you elevate one leg, so I'm going to switch over because my left leg's kind of tired, and you bring it up and out, externally rotated. What is this position called in yoga here?
Tree.
What is it?
It's the tree pose.
The tree pose, okay. So with this one, Your hands have to be on your hips. I'm losing my balance already in this position. So this is a Stork test. Hands on the hips, externally rotated leg, and come up on your toes. A normal person is supposed to hold that for 30 seconds. Jason's face is great, right? I can't hold that for 30 seconds, and I think I've got pretty good balance, right? Dr. Reskin showed me up the last time we did this. She's like, what do you mean? I can do it and hold it there for all day. Thanks, Dr. Reskin. You don't have Dunlap's disease, where your belly's Dunlapping over your belly. So that's kind of progression and standing. What else can I do? Well, I can do stepping activities to work with balance, right? Anterior, posterior. So when we're talking balance, our progressions are kind of endless. But when we're working with patients, again, first thing to do, gait belt, because they are going to fall, right? They're going to lose their balance, right? Dino discs. I like dino discs. Maybe I should start calling, oh, we could develop, hey, Oscar, we could develop those for kids and make $1 million. Right? Make the dino discs in shape of dinosaurs. $1 million activity, I'm telling you. Call them the dino discs. But all of our progression, I mean, there's a million things we can do to progress. Why is this important? Well, obviously balance is important. The other thing is balance is billed differently. Balance is billed as neuromuscular re-education. And I don't know how many of you know this, but neuro re-ed bills at a lot higher rate than just exercise. So that leads me to, well, how do you define what's an exercise versus what's a balance exercise, right? Because marching, could that just be thorax? Just sitting here marching, right? Could I do that for balance as well? Yeah. Right? So how do we split that? Well, main thing is the way we document, right? So if I'm doing marching for balancing, I'm going to put for postural control or something to that effect, for balance, for improved seated balance. So it's clear I'm doing that. The other thing is, usually in the case of exercise, we do sets and reps. So we'll do, marching 3 times 45, meaning we're doing 3 sets for 45 reps of marching. Just bang my knee. That was great. Versus balance, we'll say we did 3 sets of 45 seconds of marching. So usually balance is a timed activity. Does that kind of make sense a little bit? So that's kind of the way I differentiate, especially when I'm doing my my documentation is, if I'm doing balance, I kind of specifically put it in a balance category. So I say balance activities or a neuromuscular re-ed, and I list all my stuff for neuromuscular re-ed there, and then I put thorax and list all my thorax stuff. So it's very clear, and I can define why I'm billing those. But the other thing is, usually thorax is sets and reps, and usually involves weight, versus balance, which is reps or sets in time. So holding it, doing stuff for a specific time. One of the mistakes you can make is saying, well, how do I progress balance? Well, I'm going to put a dumbbell in their hand. I mean, yes, does that affect balance? It sure does, but that's not a 100% best way to progress balance. Closing the eyes is a good way to progress balance. Narrowing the base of support, good way to progress balance. We really don't start adding arm position, good, right? But we don't start adding weight. When we think adding weight, that's more of a thorax activity. Does that make sense? So just a thought process, because I know we're going to have a comp next semester on this, where we'll do a balance activity, and I'll say, well, how would you progress this, Jason? And Jason will be like, I'll add a cuff weight. Well, cuff weight is really, more thorax than it is balance. But he could say, oh, well, have him stand on one leg instead. Good, that's a progression. If your patient cannot tolerate your progression, what should you do?
Go back a little
Go
bit.
back, yes, especially with balance. If you're doing something like thorax, where you go from red to blue TheraBand, and they can't do 30 reps. We can lower the reps on that, right? But with balance, it's safer to go back to something they're safe with, increase the time maybe, or increase the number of sets they do of balance and then work up to that one they had trouble with, rather than just automatically saying, well, just suck it up and do it, buddy. Because that can really challenge them. And here's the deal with balance. If you have somebody's got a balance problem, if you challenge them that much, it really can it dissuades them, and it really kind of depresses them that they may not be able to do it. Think about it. If you've got somebody that's a stroke and they can't even sit in a chair upright and they're all over the place, and then you're like, well, let's try standing. And they're like, I can't even sit. Right? It really kind of discourages them. So think about that when you're working with those patients. Does that all kind of make sense? Any questions on balance? It's all a balance act. Anything you can think of? All right. Well, I know you guys are going to cry about this, but here's the deal. First time for Mr. McKeever ever. I'm going to let you guys out early. I know. Riley's like, no, don't do it. I've stolen enough late time for you guys, so let's give you guys a little half hour early today. We got through the ankles. We got through those balance stuff. So I'm going to stop recording.